Good morning, all CSI members. Coming to today's program, we have, it is a cinematic theme, isn't it? Hollywood, like the posters, the content, everything is so well, story script, everything. So it remembers me of one of the old movie, Rustam and Sorab. Rustam is a father and Sorab is the son. There's the epic story of Firdausi, in which the two legendary characters having a truly legendary story. And the Avasanam Sangadavaanangilum, epic Anangilum, Avasan Sangadavaanangilum, Adin Aditya Poleana is that Dr. Sulfikar Ahmadum Sajanum, Dandiverum, Paraso, only on the Mechavan, it is a cinematic theme of Kirigiana. I thank them all for the wonderful academic feast that they have prepared. Please enjoy. Have a nice day.
Thank you. Sergeant?
Yeah, you may please.
Yeah, I think that unfolding the theme, whatever. Good morning and to all my friends and colleagues. Thank you, Johnny and Karnadas, for this fabulous opportunity, and special thanks to my dear son, Sergeant, especially. And welcome to the Heart Shots. We have actually tried to present this webinar in a problem-solving mode, or even more precisely, searching for the right answers to certain vexing questions in cardiovascular medicine. And you know, in clinical medicine, unlike in courtroom scenarios, there is nothing like an yes or a no answer. Yet we want to reach somewhere very close to it by the end of this webinar. So that is why we have brought in young minds, young Turks among the cardiologists in our state, and also invited some of the most eminent cardiologists in the country who happen to be master clinicians and teachers to converse with you this morning. And we hope and feel that the rather exciting and delightful combo will whet your appetite for an earnest dialogue in dilemmas, caveats, and controversies in the care of cardiac patients, both young and mature. And there are some instructions which have been I have been asked to convey to you. One is the primary talks are all, as you know, recorded. Each will be followed by our director's comments, which are live. The time is not only muscle, as we always say, cardiologists say, but also of the essence. So I did not re-emphasize this to our august directors and participants. The participants can put in their queries into the chat box, and our coordinators will channel them to either the protagonist or the director, as the case may be. And for the welcoming ceremony and the GBM, please leave the current link after the webinar is over, and then to enter through a new link which has already been sent to all. And now to Abhilash and Sajan, who will be comparing and coordinating and streamlining the webinar. And may the force be with you always. Thank you. Now over to Sajan and Abhilash.
Thank you very much. Welcome, everyone. Nice to see faces without masks, very rare these days. So we will now go on to the anthology section 1, which will deal with dilemmas. The first topic is, should I routinely advise TMT for all my diabetic patients? And we had a script which went like this: 62-year-old gentleman, retired bank manager, diabetic for 14 years, on metformin, vildagliptin, and statin. He's not on any antiplatelet drugs. He is a reformed smoker. He's very active and is now planning to go abroad for his daughter's delivery and has come for a cardiac checkup prior to the trip. Of course, due to COVID, the trip may have to be postponed. But let us listen to our handsome young actor from Kottayam, Dr. James Thomas, about what he has to say in this scenario. And we have a master director also from Kottayam, our dearest Sudhevkumar sir. The AV crew, can we please have the first talk by Dr. James?
Respected teachers, seniors, and dear friends, first of all, I'd like to thank Sulfi sir for this opportunity. I will straight away go to the first dilemma of the day. Should I routinely advise treadmill for all my diabetic patients? So with the permission of a director, this is my script. A 62-year-old gentleman diabetic who is going abroad, who's come for a cardiac checkup. The question is whether to do a treadmill for him or not. So this is almost like the famous Shakespearean question, to be or not to be. The only difference is that here it is whether to screen or not to screen. We know that screening saves lives in many situations. So why are we having this debate? Because we know that the CA breast screening program is very well recommended. It saves lives. Diabetic retinopathy screening, again, very well recommended. So why are we debating about screening CAD? It's because whenever we are thinking about screening for a disease, it is said that we should ask 4 questions to ourselves. This is the first question. Is the prevalence of the disease high enough in the screened population? Here, we know that in diabetes, the rate of asymptomatic CAD is high enough. It is to the tune of 20 to 60%, a wide range because of the different ways studies have been done. But the prevalence actually justifies screening. So what is the second question? Is the test sensitive enough to differentiate between low versus high risk patient? Here, treadmill is not that strong because the sensitivity is not that high. That is around 50 to 60% if you take out the reference bias, compared to the higher sensitivity to the tune of 80 to 85% of myocardial perfusion imaging and stress echo. So what about the cost effectiveness? That is the third question. Here, the ground of TMD is very strong. It is definitely cost effective. As long as patients with mildly positive or borderline positive treadmill are not aggressively referred for CAG, treadmills are cost effective. So before going to the fourth question, I will introduce this gentleman. He is none other than the famous Cochrane, that is Archibald Cochrane, who is the father of evidence-based medicine. He once made this famous comment about screening. When someone thinks about screening, the practitioner should have conclusive evidence that screening can alter the natural history of disease in a significant proportion of patients who are screened. So that brings us to the fourth and the often forgotten question. Will treadmill lead to a treatment which will improve outcome? So the requirement of a screening test in CAD is not just to diagnose, have an early diagnosis of CAD. In fact, this early asymptomatic diagnosis should lead to a reduction in MACE and or mortality by applying some intervention, whether it is pharmacological or revascularization. So the question is whether treadmill have strong outcome data in patients with asymptomatic diabetes mellitus. We have got few outcome studies, basically 3 studies. First is by Faglia et al., 2005, a small number of patients only, less than 150 patients, and there are some advantage for treadmill, 4 events versus 15 events. In fact, this is the only study for treadmill which has got a proven advantage over not screening. The other 2 trials, the dynamic trial, which came in 2011, around 650 patients, high-risk patients, no difference with screening and not screening with their treadmill. And the famous DADDY trial of 2015, which came out in 2015, more than 500 patients, at least intermediate risk. Even though there was a numerical advantage for screening, there was no statistically significant difference. So as far as treadmill was concerned, the evidence actually is not very strong. What about the other screening modalities? That is myocardial perfusion imaging. Basically 2 trials, DIAD trial, more than 1,000 patients, intermediate to high risk, absolutely no difference. The famous BARDA trial, which came in JAC 2014, here again, there was no significant difference. So basically, it has been seen that asymptomatic diabetic patients, if you screen them with whatever modality, the data for hard events is actually not that strong. Actually, this is not completely unexpected because we know that even in stable CAD trials, all these trials, the courage, ischemia, barrier with all its limitations, the data is not that strong for interventional management, even in chronic stable angina, let alone for asymptomatic CAD patient. So what about the guidelines? What do the guidelines say about routine screening in diabetic? The US Preventive Task Force Guideline 2012, they don't recommend. ESA 2013, they do not recommend routine screening. Of course, can be done in select high-risk population. American College of Physicians 2015, they also do not recommend routine screening. ADI 2021, again, they don't recommend routine screening. They recommend screening only if there is any evidence of other vascular disease or if the patient has some symptoms, even if it is atypical, you are justified. ESA guideline 2019, they give a class 2B recommendation in high-risk patients of functional imaging. Treadmill also class 2B, especially in those patients who are planning to start a vigorous exercise program. So I will conclude like this. Will they routinely advise treadmill in an asymptomatic diabetic patient? The answer is no, simply because we don't have any data. So what will be my strategy in this patient? I will assess his CV risk, do an ECG and an echo, and treat his hypertension, lipids, and diabetes as per guideline. But the question is, will I always be able to practice what I preach? Because we know that very often it may not be possible, because this gentleman has come for a treadmill. He may be disappointed because when he suggests that the ECG and echo may be enough, sometimes he won't be satisfied. So if you still want to do a treadmill, then I will go ahead with the treadmill. So the question is, what after the treadmill? If it is negative, it is a happy ending. The patient is happy and the doctor is happy. And even if it's mildly positive, borderline positive, or this equivocally positive, again, I will stop at that point. I won't evaluate the patient further. Even if it is inconclusive or could not exercise, again, I will stop here. I won't go for any perfusion imaging. That will be the end of the imaging. The problem is, if it is positive, then we are in a tough situation. Here we'll have to discuss regarding the option of CAG versus medical management. The patient is really keen, then I'll of course go ahead with CAG. But I know that I won't be evidence-based in that decision. Otherwise, I'll be happily putting on medical management. If it is strongly positive treadmill, then of course I'll have to suggest a CAG. So I will leave you with this message, this famous message, that is, first do no harm. So whenever we are thinking about screening, so this message should be always on our mind. Thank you.
Thank you, Dr. James, for the very clear and practical suggestions. Over to Sudhevamar sir, the director.
Director, not antagonist. Thank you. Because I don't want to antagonize whatever James say. And thanks to Sulfi Sarjan for including geriatric cardiologists also to this field. Now, he has put it very clearly. Now, here the issue, I'll take it, whenever we get a person or a patient for evaluation, you are looking at the disease, you are looking at the patient, you are looking at the society, and you are looking yourself and your colleagues also. These are the complex factors which have to be considered in making decision in any situation. But in an academic level, I will discuss like this, considering the social aspect. He is planning to support his daughter and family for her delivery. So he has made up his mind to go. So the question is whether we should support him to have his peace of mind and pleasure of supporting the family, versus are you interested in screening him for an asymptomatic coronary artery disease? This part I will discuss with him first. Are you keen? Which is your priority? Is it hearing your daughter's delivery issue versus your own possible asymptomatic positive treadmill? That is a situation which I will handle first. That is what I call it as the social medicine or the family medicine. Because as Dr. James has said, there is no role for a treadmill or a stress test in an asymptomatic. Here I will not take it as a very high risk because he is only a diabetic. He doesn't have other risk factors. So we can look at the score also. What is his chance of developing problems in the next 5 years, whatever it is. He may come under the, I'll put it as a low intermediate risk. So here we have to discuss with him whether he is keen to have a evaluation or a fitness program before going to daughter's issue. Now, as Dr. James has put it, as per the literature, the only indication for a routine stress test in an asymptomatic patient is for getting involved in an exercise training program or like that. Otherwise, as per the literature, there is no recommendation. But as he has put it rightly, that we deviate from this based on so many factors. So many factors, I said, the patient side, then our colleague side. Suppose a person, one of our colleagues has recommended treadmill. I think then obviously we have to do that, because otherwise there will be a controversy, confusion in his mind. So that is a number one issue. So here I thought that he has made up his mind, and that may be more important than this thing. So my issue comes as what is the background in which we are doing. So in this case, as Dr. James has said, I will also discuss with him what are the benefits, pros and cons of doing a treadmill. And the way I discuss will be slightly different from what some of my colleagues may be doing. I have made up my mind that this question should not be submitted for a treadmill. Now this, my colleagues, some of the colleagues may differ. But I have made up my mind that I don't want treadmill in this thing, because as Dr. James clearly put, at the end of this thing, if it shows some ST depression, the whole thing becomes MS. So then I'll be discussing it in such a way, what are the limitations of doing treadmill? Will it interfere with your plan? All those things, so that finally I will almost make sure that I will send him without a treadmill. That is my personal dealing, not 100%. I think it is supported by data also. On the other hand, this person comes to me, am I likely to develop any problem? I am traveling. Suppose I go there, I develop some problem, and then they will be in trouble. The whole thing will be whether they will be keen to take my problem or the delivery, all those things. Then I will definitely submit him for a treadmill. And if the treadmill shows some change, definitely I will go ahead. That is not based on the literature or recommendations, based on that background, which I think is the most important. Because any recommendation says that whatever is given in this has to be applied based on the clinical background. Clinical background, which include the disease pattern plus the other background also. That is the way I looked at it. That is my view. We can talk so many things, so much time, but time is limited. So I will like to put two issues related to TMT, which I am facing regularly. Number one is there any why we are including treadmill for routine executive checkup? That is a mistake which we have made. Then we are trying to discuss on that. In routine executive checkup, there is ECG, water blood profile, all those things, and then comes treadmill, not a clinical evaluation. There is no role about the clinical evaluation by a competent person. I will put it as competent person before doing treadmill. So that is not there. That is the issue. I am sure James will have his own views on that. That is one thing. Second thing, I still feel that a proper clinical history risk stratification will be much, much more useful than a treadmill. The second situation which I have been facing, not always, not in all areas, is a patient come for a non-cardiac surgery. I have seen few of the colleagues, not only the cardiologists, then the physicians, surgeons, insist for a treadmill preoperatively. And is it really needed? I think there are solid recommendations for an evaluation in a patient. I think Dr. James will be a better person because he's reading more than me, and he is more dynamic, glamorous, film star. So he'll be touching on these two issues. James, I hope you can.
Yes, sir. I also personally feel that I think we are overdoing treadmill as part of the executive checkup because we don't have any data. Like you rightly said, I think we should focus more upon evaluating the patient, properly assess the risk score, and see whether all other risk factors are controlled in the guideline-driven manner, rather than straight away going for a treadmill. I think it may be counterproductive, and we are not actually supported by data also. So I think I fully agree with you in the first question. Regarding the second question also, I think we have regarding the preoperative evaluation for a non-cardiac surgery, I think we have the ESC guideline, just like you said. I think they are also very clear. That is, if you have a emergency surgery, of course, you will go ahead with the surgery. Other than that, basically, they also advise to divide patients into low-risk surgery, intermediate risk surgery, and high-risk surgery. Low-risk surgery is like a cataract surgery or a thyroid surgery, should straight away go for surgery after a basic evaluation. They should not be going for a treadmill. Even intermediate risk surgery, if the patient has got enough physical activity, at least more than 4 METs, I think we can go ahead with surgery. Only if it's a high risk surgery, then the recommendation is suppose if and the metabolic activity is less than 4 METs, and if you have multiple risk factors, that is the only situation when the guideline actually encourages us to do a treadmill. So the role of treadmill in preoperative evaluation is also not high. I think that we should be doing less number of stress tests preoperatively. That is my view.
Thank you. I think we will be coming to the close of the session with the director's permission. One question from the audience: should we discourage the practice of including treadmill test in routine health checkups? Dr. James or Dr.
Okay.
Please. Also, there must please.
I strongly feel that should be excluded, and if at all you can include echocardiogram, because at least you get some idea about the major risk factors. For example, when you are doing the echo, we will ask what is his symptoms, so get an idea what is his effort tolerance. The second, you can have the LV function. The rhythm problem you can easily assess by looking at this history and the pulse. So I think we should give a recommendation that the treadmill should be replaced, if possible, by the echocardiogram. The revenue generated by the institution is the same. The time spent by the cardiologist is also less, because we know it's a normal, we can finish the echo, the technician will do, and we can finish it in 2 minutes time. I think that will be my message. And I think time to conclude, just I'll put in my usual talk, the whole decision depends on these two factors: the aggressive, conservative, the team, patient. Aggressive patients, aggressive consultants, no problem, aggressive approach. Conservative team, conservative patient, easy, conservative. An aggressive patient coming to either of us, it is aggressive. But the majority of cases is conservative patient coming to an aggressive team, it makes a little confusion. Thank you so much for the chance to give us. Thank you, Dr. James, for the wonderful presentation and the way you handled my question, the ESC question, in a very simple manner. Thank you. Thank you so much.
Thank you very much. Thanks to the director and the protagonist. We now go on to the second short story. Should I routinely post-dilate or not during my primary PCI cases? We have the young Turk, so to say, Dr. Paul Thomas, and our dear Dr. Bahule CG sir as the director. AV team, can we have the second talk, please, by Dr. Paul Thomas.
Morning, one and all. Respected chair, my director, teacher of my teachers, Professor Bahule sir, my teachers, senior members, and dear friends. At the outset, I would like to thank the organizers for giving me the opportunity to present before this august audience. Straight away go to the story. It was 1 a.m. in the night. The 40-year-old gentleman who has been a smoker presented with installation myocardial infarction, RVMA, AV block, and hypertension. Was taken to the cath lab for a primary angioplasty. His coronary angiogram showed 2 vessel disease, mid-RCA totally occluded, and 80% lesion in the LAD. Temporary pacemaker was inserted. Then thrombus aspiration was done. 1 long DES was deployed at nominal pressures. TIMI3 flow attained. BP was stable, and the rhythm became normal. Now, should I post-dilate this case or even every case of primary angioplasty? At 1 a.m. in the night, should I strive for the best despite having a good result and cross the Rubicon, or retreat from the war thinking that best is the enemy of good? I would like to review a few key actors in this play. So regarding thrombus aspiration, with the total trial, the enthusiasm of thrombus aspiration has waned off, but still it has been indicated in lesions with large residual thrombus burden after opening the vessel with a wire or a balloon as a bailout procedure. This patient, being a smoker, is expected to have a heavy thrombus burden. Next, regarding the stent sizing, in acute myocardial infarction, it's known that there is intense vasospasm in the vessel. Undersizing of the stent can occur. That will lead to further MACEs. So, if the BP permits, liberal use of vasodilators prior to the stent selection should be done. It's preferable to have a 1:1 sizing of the stent. And it goes beyond without saying, DES, the new generation is the rule. Still, if there is a heavy thrombus burden, the mesh stents like MGuard or the self-apposing stent can be used if it is available. There is no much data regarding the stent deployment pressures that has to be followed. Still, the data from the Swedish registry of over more than 90,000 stent implantations, which included 20 to 30% of STEMI cases, these patients were divided into 3 groups, and stent thrombosis and stent restenosis appeared to be higher with low and very high pressures, but not in the medium pressure group. There was no difference in mortality across the groups with regard to the stent dilatation pressures. Also, slow decremental stent balloon deflation also has some role, as some studies have pointed out. Regarding the adjunctive pharmacotherapy, I would definitely resort to prasugrel or ticagrelor for this patient, as well as GP2B3 inhibitors, either as an intracoronary or an intravenous administration. Regarding the TIMI3 flow, microalveolar obstruction cannot be predicted from the TIMI3 flow alone. Even if you have a TIMI3 flow, it's better to have a TMB, myocardial blush rate, or even the corrected frame prone to prognosticate the patient. Now the question, should I posteriorate in primary angioplasty? Bigger is better. That was a technical cornerstone of the BMS era. With the advent of DES and IOS evaluation, it was found that suboptimal stent expansion and MSA was seen to be associated with restenosis, TVR, and stent thrombosis. Gary Means et al. Showed that DES achieved only 66% predicted MSA, and the stent optimization of top study showed only 21% DES showed optimal deployment at 60 atmospheres, 54% after post-dilatation at 20 atmospheres, 81% had an optimal deployment on IOS guided optimization. In cases of acute coronary syndrome, there is higher risk of stent thrombosis due to increased platelet reactivity, lack of endothelialization of vascular endothelium, delayed healing, and exposure to inflammation and coagulation environment. Even the stent balloon dilatation with the semi-compliant stent balloon at higher pressures can sometimes lead to stent edge dissection, coronary perforation, and intimal injury. This lead to increased inflammatory response and higher restenosis rate. The new generation thin strut DES, there is a chance of recoil, and they also require post-dilatation with an NC better. But of late, I shouldn't post-dilate routinely in PAMI because no major RCTs are there to prove hard endpoints of MSE. Despite having optimal stent expansion and large CSA by IOS guidance, no major studies could point out to a hard endpoint. The current generation of stent delivery balloons are less compliant, allowing higher pressure implantations, especially in type de novo lesion vessel with more than 3.5 millimeters or a soft lesions. These could achieve a large cross-sectional area with stent balloon itself. Apart from the dreaded complication of slow flow in a thrombotic milieu, aggressive post-dilatation might result in more intimal hyperplasia, head dissection, geographic miss, greater side branch occlusions, and myocardial injury, risk factor for a stent fracture or a restenosis and coronary perforation. Longitudinal deformation in the new generation thin strut test is also a problem. Above all, operator experience and discretion and case-by-case approach is the best option that can be taken. Very few studies like these meta-analysis have some conflicting results. Yang Lee et al. Pooled data of 11 studies and found that there was some reduction in risk of MAC after post-dilatation in acute coronary syndrome, but there was no effect on stent thrombosis, MI, or TVR. They had a significant increase in all-cause mortality. Another analysis, meta-analysis by Jun Cheng, showed that there was no significant difference in the post-dilatation group in regard to MAC, recurrent MI, or TVR. A cohort analysis showed there was some secondary endpoints were reduced on routine post-dilatation after primary angioplasty. The post-hoc analysis of base ACS prospective RCT, 43% underwent post-dilatation. At long-term follow-up, those who underwent post-dilatation had less non-fatal MA, but the MAC rates were not significantly different in both groups. Regarding imaging primary angioplasty, the easiest and the safest imaging will be a stent boost or a clear stent to look for any under-expansion and focal post-dilatation of that segment. With if you have the liberty, or even if you have the freedom of using OCT, then intrastent plaque or thrombus protrusion, residual dissection, these also can be found out, which lead to adverse cardiac outcome. Intravascular IVS will show an intrastent tissue blocks, which shows potent severe prognosis. Of late, at 1 a.m. in the night, if you are a single man working in a single man center, you're doing a primary angioplasty in the night. Even after counting for the diurnal differences, timing of presentation, and the lesion characteristics, the success rates have been found to be lesser. That cannot be explained beyond the logistic issues. So at 1 a.m. in the night, I think I won't post-dilate this case and we'll watch for the sequel, because the storyline leaves a LAD 80% lesion, which I can title before the patient is being discharged, which is a class 2 recommendation as per these studies. I will do a check angio of the RCA and will do an imaging with IVS, or even if I have, I will do an OCT imaging of the RCA, and will do optimization under the imaging guidance and do the LED angioplasty. Thank you. As everyone
Thank
of
you.
us do, I do look forward for the director's cut on the master teacher guidelines, sir. Thank you.
Thank you, Dr. Paul, for the excellent scientific and cinematic talk. Over to the Evergreen Director, Bahulan, sir.
Thank you, Sajan, and thank you, Paul, for your excellent managing this wonderful case in a very odd hours. And it was a right coronary artery lesion, and it was totally occluded. I agree that plenty of thrombus burden lesions, and the patient has got a coexisting lesion in the LAD also. So very high risk. Fortunately, the hemodynamics were okay, except for the AV heart block. So you first has taken care of with a temporary pacemaker. And although we have not very good support for the aspiration catheters nowadays, with several trials after the TAPS trial, you have used it. I also would certainly use when the patient has got a total occlusion of the right coronary, which has got high thrombus. And then, of course, you found that the lesion is long, and used a long stent in a nominal pressure. Absolutely right way of doing that. But I am only wondering what was the size. Usually the right coronary arteries are large in size. So when a long lesion and a large vessel, what should be the size of the stent? So sizing becomes very, very important. Appropriate size in 1:1 stent with a nominal pressure. And if you get a good T3 flow and good myocardial perfusion grade, you will stop at that level. And that is why I certainly agree with you in your strategy of that. And your last slide of saying that when you take them for total revascularization of the patient to address the LAD, you would certainly look into the RC also. I think that is very reasonable. If you take the patient for LAD, this thing, you should look into the RC, because you have given only a nominal pressure. If it is a larger vessel, very likely that you will leave it malapose or underexpanded, and that can be taken care of, especially if you have an imaging device with you. That makes a perfect procedure and perfect long-term. Good results on one side. That means post-dilatation takes care of expansion, under-expansion. The other side, you have no reflow phenomenon and more problems. So that is why it is debated. So certainly there is no place at the moment. You have shown so many studies also. There is no consensus. But of late, people have shown that with newer stent struts, and newer antiplatelet medications, we find that if it is really required to post-dilate, don't be hesitant, do that. That is what my message. Nowadays, what I would like to do that, if I find that the stent is underexpanded by angiographic reasons, whether it is by stent boosting or otherwise, then I will certainly dilate with a non-compliant balloon to a higher pressure. Or if it is a larger vessel, of course, semi-compliant with a nominal pressure. Whatever may be the situations, I will do a post-dilation. A long lesion, especially tapering vessel, when you find that you decide the stent size based on the distal reference, the proximal size of the vessel is large. So you will have to use a post-dilatation. Nowadays, we get elderly patients coming with acute MI. You don't hesitate to do the PCI, primary PCI. They have calcified lesions. If you do only a nominal pressure and an precise size, it is a bad situation. So you may have to dilate. And you also come across culprit lesion as bifurcation. Maybe in the non-LM situation and even LM situation, we find bifurcation lesion presenting as acute anterior MI. So there you have to do a port, certainly. And if you have to do a kissing balloon inflation, you have to do even in a provisional stenting strategy. 2 stent strategies is where as much as possible avoided. But even if you opt to do a provisional stenting in a culprit bifurcation, you will try to do a port where you have to use a proximal vessel size stent to a higher pressure, preferably non-compliant balloon. So I think selected situations, you have to use the post-dilatation even in a primary PCI. That would be my suggestion on this topic. Well, of course, now recently people have started using imaging devices, intravascular ultrasound. You yourself have pointed out that it reduces TLR, it reduces stent-related failures, and even there are pointers to say that mortality reduction is there if you utilize IVS. But the problem is that can we use IVS in all cases of acute MI? Say in your case, Your intention is not that. You want to get the blood flow down and the patient get back to the safer side. So, but if you have any doubt of underexpansion, any complex lesions, if you have provisions for imaging, please do that. It is rewarding. Please do that and act according to that. You will not overact and you will not underact if you have an image-guided information with you. I think these are my points on this topic of post-dilatation. I will certainly not for a systematic, regular post-dilatation as in the case of elective PSA, but I will not hesitate to post-dilate it in situations where I feel that it is required. Thank you. Thank you, Paul. Very nice talk from your side. Very nice case and an excellent way of conducting this program by the great father and great son, Sulfi and Sajjan. Thank you. Thank you very much.
Thank you very much. Thank you. After that excellent talk and comments by Bhavalen sir, I think there are no additional questions. Shall we go to the next session?
Thank you.
Yeah, thank you, sir. Thank you very much. Thank you, Dr. Paul.
Thank you, sir.
Now we go to the third topic of the day. Should I withhold beta blocker initially in my acute decompensated heart failure patient? We have a handsome actor yet again from Calicut, Dr. Rajesh Muralidharan, and yet another legend, Dr. Vijayaraghavan Ji. Welcome to both. Can we have the talk by Dr. Rajesh?
Good morning, everybody. First of all, I thank Sulfikar sir and Sajjan for this opportunity. It's indeed a proud privilege to be presenting in front of this august audience. So over the next 8 minutes or so, we'll be dealing about this specific question: should I withhold beta blocker therapy initially in my patient with acute decompensated heart failure? So Sajjan has given this story of a 70-year-old female with coronary artery disease, previous anterior MI, recurrent ACS, severe LV dysfunction with an ejection fraction of 30%, moderate mitral regurgitation. She has 3-vessel disease, advised medical management. She is now admitted with worsening of dyspnea, orthopnea, and is day 1 in ICU. She is in pulmonary edema and receiving IV furosemide on intermittent non-invasive ventilation. BP is maintained 110/70. I presume the renal output is also maintained, mild worsening of renal function, and she is on 3.125 milligram PD of carvedilol. Now the question is whether it should be stopped or not. To answer it in one word, yes, beta blockers should be continued in this scenario. Now, to put things in perspective, let us see where this patient fits in the natural history of heart failure. The natural history of heart failure is one of chronic decline, punctuated by these acute episodes where the patient lands up in hospital. So our patient has landed up in one of these troughs or hospitals. He is on a chronic beta blockade therapy, and now he has hospitalized with a decompensation. It's not one of those patients who has fallen into one of these troughs after a recent dose change, or one of those de novo patients with heart failure in whom the beta blocker was initiated. In these two scenarios, there is no question. We have to stop beta blockers because these beta blockers might be the reason why these patients have decompensated. Whereas in this patient, there is a chronic beta blockade therapy, and now the patient has landed up with a decompensation. Now, why should one want to stop beta blockade therapy in this scenario? What is the logic behind it? In the era of Eastman color, we thought that heart failure is predominantly a hemodynamic disease, and our aims as well as treatment were aimed at improving the autonomic nervous system or increasing the output of the autonomic nervous system, increasing the inotropy and increasing heart rate. Over the years, we have learned that it is not the case, and this chronic activation of the autonomic nervous system can be deleterious. So in this era of 4K HD imaging, we treat these patients with beta blockers. When somebody takes out beta blockers out of the equation in a patient who has acutely decompensated, his logic is that he would actually do away with the latter part of the equation temporarily and hope that whatever little negative inotropic effect as well as the chronotropic effect that beta blockers had will also be taken off, so that it would at least provide some support to a ventricle that is failing. Or in other words, removing beta blockers in this scenario can be considered as something similar like adding a positive inotropy, as trying to add a positive inotropy to a failing ventricle. But studies have shown that this logic doesn't work. In the earliest of the heart failure registries after beta blockade came into routine use in patients with heart failure, like the optimized heart failure trial, it can be seen that patients in whom the beta blocker were withdrawn or not treated were having a higher mortality rate compared to patients in whom beta blockers were continued or newly started. The literature is scant in this regards, and this is the only meta-analysis which also includes the only small randomized control trial which happened in this burning issue, where it shows that both the in-hospital mortality as well as rehospitalization first mortality is actually worse in those patients in whom beta blocker are withdrawn. Coming to the more contemporary of the data, the Csi Heart failure registry data, which actually was published in 2021 January, it shows that beta blockers are amongst the molecules which are most likely to be fiddled with when somebody lands in hospital with a decompensation. Beta blocker is either withheld, or it is discontinued. And these patients have a higher hazards of all-cause mortality compared to those patients in whom beta blockers are either initiated or the dose is escalated. What's worse is that this actually further complicates the therapy. Once the beta blocker is discontinued or withheld in hospital, the chance that to further increase the dose in the further follow-ups is also less likely. Of fear of that, these patients may decompensate again once you step up the beta blocker. So the odds that these patients will reach the maximum target dose of, or the recommended dose of beta blocker in heart failure is also less likely. So in a nutshell, withholding beta blockers in this scenario of acute decompensated heart failure actually is associated with the increased all-cause mortality, and it is also associated with decrease in the dose that a particular patient would achieve over the course of time. Now, why withholding beta blockers doesn't help in acute decompensated heart failure? If you see the elimination half-life of most of these drugs that are most commonly used, most of them is approximately around 7 hours. So this is the time when you expect that there will be some positive inotropy to the failing ventricle and you are expecting some benefit. But it takes at least 7 hours for the molecule to wash out. So that's one of the reasons why beta blockers, stopping the beta blockers doesn't acutely help in patients with acute decompensated heart failure. Other reasons include enhanced sensitivity to beta-adrenergic agonists on abdominal withdrawal, paradoxical activation of the sympathetic nervous system, and exacerbation of angina, arrhythmias, and sudden death. Even the guidelines are moving away from positive inotropy in patients with decompensated heart failure. This is from the ESC guidelines. Inotropes are not recommended unless the patient is symptomatically hypotensive or hypoperfused because of a safety concern. And if at all we have to use a patient, if at all we have to use a inotrope in a patient who is on beta blockade, when you think that beta blockade is contributing to hypotension with hypoperfusion, beta blockers should be withheld, and you should use a drug like levosimentan or milrinone. So coming back to our patient, where does our patient fit in the matrix of acute heart failure, this clinical profile of the acute heart failure? Our patient is congested, but there is no hypoperfusion, or in other words, our patient is warm and wet. So in these patients, beta blockers need not be changed. In fact, surgeon should try to hike up the dose of carvedilol because he's just on a minimal dose of carvedilol. Once the congestive symptoms are taken care of, beta blockers should be hiked up, and inotropes are usually not required. If you take a twist in the tail and tell that the BP of this patient is 70, then there is a sign of hypoperfusion, and in which case inotropy comes into question, and in which case beta blockers may be withheld or the dose may be decreased, and the diuretics should be increased to take care of the congestive symptoms. Same is the profile in patients. Same is can be seen in patients with this cold and dry patient, where the beta blockers may be withheld or decreased and when inotropes are required. So there is no one answer to the question, should I withhold beta blockers in my patient with acute decompensated heart failure? Depending on the profile of patient, which is most commonly warm and wet, the beta blockers need not be changed. Or if you think that beta blocker is contributing to the hypoperfusion and hypotension and inotropy is required, beta blocker dose may be withheld or the dose can be reduced. Thank you for your time and patient listening. We'll move on to Vijay Raghavan sir for his comments. Thank you.
Thank you, Dr. Rajesh, for that opinion. Vijay Raghavan sir, please, over to you.
Dr. Rajesh, you have done very well in discussing this particular patient. And I'm quite happy that you went through every aspect of beta blocker therapy in acute heart failure. You said it's absolutely correct. See, beta blocker therapy is basically contraindicated only when you find cardiogenic shock, which I've already stressed, when they receive a bradycardia, hypertension, or wheezing related to asthma. These are only contraindications to beta blockers. Otherwise, contrary to what was believed. Probably you may not know that when we started using propranolol, the year I joined, MD propranolol introduced as in 1967, cardiac failure was a contraindication. Later, it became an indication. And today, as we find the present discussion, it's a must in patients with heart failure because it reduces all the sympathetic overactivity and its actions on the heart failure. But remember, what are the main ways to titrate the dose of beta blockers? Titrating the dose of beta blockers is number one, the heart rate. Number two is the blood pressure. And here, the heart rate is 160. There is no need to withdraw that small dose of carvedilol patient was taking. I fully agree with you. But if you find the heart rate is low, that is the time to think of whether beta blockers are harming the patient. If you find the blood pressure is low, that's the background in which we have to think of whether this is a background to withdraw the beta blockers. Otherwise, beta blockers should be continued in all these patients with heart failure if the patient was already on. There's a de novo situation. Patients comes to you with first episode of acute decompensated heart failure, class for heart failure. Will you start beta blockers at the time of admission? That's the background at which you do not start in a patient present with acute pulmonary edema for the first time in his life. That's the time you want to get out of the class 4 situation, get out of the acute phenomena, pulmonary edema, and wait for patient to settle down to start the beta blockers. That's the thing to be understood. For the first time patient getting acute pulmonary edema, don't go ahead with the intravenous beta blockers at the very beginning. You have to wait till settle down to class 3 and then start the beta blockers and titrate the dose of beta blockers as per the heart rate as well as other parameters. Otherwise, there is nothing more to include in what Rajesh has beautifully discussed. Every aspect of beta blockers you have discussed, and please understand, beta blockers have become the mainstay in the management of heart failure, and this is one of the drugs which prolongs longevity and should always be thought of, except when you have strict contraindications as bradycardia, hypertension, or acute allergic wheezing, as we know in patients with bronchial asthma. These are the only situations. There are drugs which are contraindicated, other than beta blockers, which are negative inotropes. Classically, calcium channel blockers, negative inotropes, which are contraindicated. And if you find the beta blockers are contraindicated for the heart rate control, you may have to introduce ivabradine to control the heart rate if the patient is in sinus rhythm. Otherwise, beta blockers is an absolute must in the management of heart failure, whether it is acute or chronic. In acute, after the patient is phased down to class 3. In chronic, the patient is on beta blockers. Even if the patient comes with an acute episode of heart failure, please continue the dose he was on unless there's a contraindication. And retitrate the dose of beta blockers once the patient has come out of the acute episode and come to class 3, and then decide on the heart rate and the blood pressure. I think these are the few points which I would like to add. I don't think I have added much to what Dr. Rajesh has beautifully discussed in relation to what are the use of beta blockers in heart failure. I would like to thank Sajan and Sulfi for organizing this program. And this was very, very well as case discussion, which stimulates the youngsters as well as the elders. Thank you.
Thank you very much, sir. There was a question from the audience. How fast should we up-titrate beta blocker once we have reintroduced after temporary withdrawal?
Even if you are temporarily withdrawn, you have to wait for them to go to class 3. There are bisoprolol people dedicated to bisoprolol who do not withhold the beta blockers will continue. But I personally feel class 4 is not a phase at which you should titrate upwards. Wait for patients going into class 3, stable blood pressure, and patient feels comfortable. You can up-titrate the beta blockers to control the heart rate. It's a very important part of management of heart failure.
Thank you, Dr. Rajesh and Vijayaravan sir, for that excellent discussion. We will go on to the last topic of this section. When and how should I start statin in pediatric dyslipidemia? So what would the world be without women? So we have a female protagonist, Dr. Renu P. Kurup, and we have a very hard taskmaster of a director, Shivashankaran sir, when it comes to diet. So over to Dr. Renu P. Kurup. Can we have her talk, please?
Good morning, everyone. So today's discussion is a practical approach to the management of dyslipidemia in children, when and how to start statins. When you look at the lipid values in children, they differ from adults and vary depending on the age. At birth, the lipoprotein levels are very low, and in breastfed babies, there's a higher cholesterol content. During infancy, both the cholesterol and the triglyceride levels are significantly low, and they gradually increase to reach around adult level by around 9 to 11 years of age. At the level of puberty, there is a drop in almost 10 to 20% drop in LDL cholesterol and total cholesterol, and predominantly so in the boys. And then again, the turn around and reach the baseline by around second decade of life. So defining pediatric dyslipidemia is total cholesterol of more than 200, LDL cholesterol of more than 130, HDL cholesterol of less than 40, non-HDL cholesterol more than 145, and triglycerides more than 100 in children less than 10 years and more than 130 in children more than 10 years. So now how do we detect these children? They have to be detected by screening, which is usually selective screening, that is a targeted screening in children who have any disease which predisposes them to cardiovascular disease like diabetes or the presence of any other risk factors. Cascade screening is done where there's systematic family trees, that is screening of all the relatives of close relatives of an index case. All children 2 years or older with a first or second degree relative with a record history of premature cardiovascular events, that is less than 55 years in a male and less than 65 years in a female, should be screened. The problem with the selective screening is that when you screen them, we miss a considerable number, almost 30 to 60% of children with dyslipidemia. So that means universal screening has to be entertained. But this is a very controversial topic. Universal screening has been recommended once during 9 to 11 years and at 17 to 21 years. Birth to 2 years, we don't screen them, and we don't usually screen them between 2 to 8 years and 12 to 16 years unless there's a significant family history or the patient itself has, or the child itself has risk factors. Now, once screened, how do we diagnose them? That is, these lipid levels are cut off into acceptable levels, borderline high levels, and high levels, depending on the various fragments have been designated that. And the example, total cholesterol less than 170 is acceptable, and more than or equal to 200 is considered as high. So once you diagnose dyslipidemia, you will have to manage them. So how do you screen these children with cardiovascular risk factors? So screening begins at the age when risk factor is identified, or in children who have familial hypercholesterolemia or strong family history, you screen them after 2 years and screen them once in every 3 years, 1 to 3 years. And with that variation has to be depending on the individual risk profile. Now, what do we do to screen them? We screen them either by a fasting or non-fasting lipid profiles. And if the initial non-fasting lipid profile is abnormal, then the follow-up test has to be fasting lipid profile. At least 2 fasting lipid profiles should be done 2 to 3 months apart before you confirm an abnormal screening test. Now, once diagnosed, we have to manage them. The first step in management is to classify them into risk. That's a risk stratification. You risk stratify them into high risk, moderate risk, and at risk, depending on the risk factors. And once this is done, you assess for other cardiovascular risk factors or comorbidities. So the importance is that if a child belongs to moderate risk and if has around more than 2 other comorbid factors, we have to consider them not as moderate risk, but we have to manage them as high risk. So treatment of hypercholesterolemia per se, there are non-pharmacological measures and pharmacological measures. For non-pharmacological measures, predominantly is the heart-healthy lifestyle changes. That is dietary modification, enabling physical activity, promoting weight loss, and avoidance of nicotine. So one of the best approaches to guide the parents to create a positive, healthy home environment. Ensure adequate sleep, Make sure that all of them have breakfast and decrease the screen time. Dietary modification usually go by a staged approach, that is start with a high fiber diet, which is high in polyunsaturated and monounsaturated fatty acid, and the saturated fat should be low and it should be devoid of trans fats. The total fat should be less than 30% of the total energy intake. The saturated fat should be less than 10%. Practice this for 3 months. Again, repeat the test. If the hypercholesteremia persists, you have to go for again further diet fat restriction to 25 to 30% of total calories and a saturated fat of less than 7%. Now, pharmacologic therapy is reserved for high-risk patients as well as those who do not achieve adequate response to lifestyle changes. And of course, the first-line drug is statins. Of the 7 statins described here, 6 are approved for pediatric use, and the choice depends on the level of control you need, and of course, depending on the availability and the price. So statins usually start at the lowest dose once a day, and usually at night hours, because the cholesterol synthesis usually occurs during night hours. And the side effects, though rare, which have been highlighted are myopathy, new onset type 2 diabetes mellitus, hepatic enzyme derangement, and the risk of teratogenicity, especially in adolescent girls. So what has to be monitored is the fasting lipid profile, creatine kinase, alanine aminotransferase, glucose, and HbA1c level. So what do? You monitor them and then start on initiate therapy at lower dose and look for any signs of toxicity. If there are signs of toxicity, stop the drug, redo the test. If they are normal, again come back, restart the statins. If there are no levels of toxicity, no signs of toxicity, you go ahead till your goal is reached. If it is reached, continue the same statin dose and repeat the test once in 6 months. If your goal is not reached, you have to go again upon the statins to 10 to 20 milligram. Repeat follow-up every once in 4 weeks with the test. And if there are any signs of toxicity, you go back to the previous one. If your goal is not yet achieved, you go to the maximum dose possible and look for any toxicity. So you have to repeat the test for every dose change. And if still it does not reach, then you have to add a second drug. Now, management of children, you take up less than 10 years, predominantly it's lifestyle changes, and you add medications that is statins only if they have high-risk cardiovascular disease condition, LDL cholesterol is more than 100, your triglycerides are more than 1,000, and there's a very strong family history of premature atherosclerotic cardiovascular events. In children who are more than 10 years, high-risk patients, you have to start both therapies simultaneously, the target of LDL cholesterol less than 100. In moderate risk patients, you have to predominantly lifestyle changes for a period of 3 months. Repeat your test after 3 months. If the LDL cholesterol is more than 160, start statins. In at-risk patients who are above 10 years, and in other patients, other children who have cholesterolemia, hypercholesterolemia, but there are no risk factors, the lifestyle changes continue for 6 months and repeat the test. And LDL cholesterol still remains more than 160, start statins. And the treatment here, the target is less than 130. To conclude, pediatric dyslipidemia is often underdiagnosed. Universal screening, though controversial, can be practiced, and at 9 to 11 years and 17 to 21 years. Children with a strong family history or other risk factors should be regularly screened after 2 years, and lifestyle modification forms the primary mode of treatment. Statins may be indicated in high-risk patients and if dietary therapy fails. Now, coming to our patient, who is a 14-year-old boy who is obese, the BMI of 24.5 with both parents diabetic, and his hypertensive, that's a BP of 130 by 74, and a deranged lipid profile. We look at it, he comes to the at-risk category, but he has 2 associated comorbidities, that is, this has a family history of diabetes in the parents, and along with that is hypertensive also. So he can be treated as moderate risk, that is, dietary therapy or a lifestyle modification for a period of 3 months. That is with a target of BMI less than 90, with a BP less than 90th centile, and LDL cholesterol less than 130, and fasting glucose less than 100, HbA1c less than 7%. Along with this, promote him to the daily physical activity, limited sedentary activity to less than 2 hours, promote weight loss, and then if after 3 months, if his LDL cholesterol remains more than 160, start him on statins. Thank you all.
Thank you very much, madam. Now, over to Shiv Shankaran sir for his comments.
You have systematically covered when to screen, and you have reconfirmed the importance of excluding secondary causes, the very, very important importance of lifestyle management and other respective control. And we have some reasonable idea why we should start statins this fall. But the scientific committee has taken us to $1 million question, because humans are the only species prone to heart attacks, essentially because of a different lifespan and different lifestyle compared to the rest of the species in this world. And more important, it was an excellent summary. Also, we have often asked this question, the problem, and taking onset and progression of the last the last 22 decades, we got very clear-cut idea about this. LDL molecules carried by the apobeal lipoprotein, so less than 70 nanometers in size, get filtered across the endothelium, get retained there, and start the disease process. And if we're able to keep the LDL cholesterol below, which is 70, which is achievable and is tolerated, rapidly produces the optimal cardiovascular health allowance. More than that, Dr. Helen House from the Dallas surgery category showed that there are at least 2% of the population. They got LDL level below 70 milligram per deciliter from birth. They got 8 times less chance of atherosclerotic cardiovascular. And these genetic studies have focused on about 6 genetic abnormalities, which helps us to keep our LDL level below 70 milligram per deciliter. And that essentially has translated to discovery of a variety of new drugs, including PCSK9. So statins, their pleiotropic effect, when you start around the age of 40 or 60 years, a 1 millimole reduction in blood cholesterol level or LDL cholesterol level translates to 20% reduction in cardiovascular events. But if we have these genetic disease that brings down this 1 millimole per deciliter, without it pleiotropic effect, we translate it to a 50% reduction in the cardiovascular events over the life. So the outcome is phenomenal, and it is extremely important to keep the cholesterol level below the 70 milligram per deciliter. So that has taken us to a new concept, not only the LDL cholesterol elevation, but also the duration using cardiovascular risk, which can calculate this as the LDL pack years. And for this boy, if you calculate the LDL pack years at the age of 40, comes to 6,400. So what does that mean? So you can see that if you've got an LDL of 125 milligram per deciliter, we have got at 40 years, we already reached the 5,000 number, which confers you 1% cardiovascular risk at the age of 40 years, 1% chance of developing a cardiovascular event. And if you maintain this boy at 6,400, you're going to have a 2% risk, almost double the risk at 40. And if you by some means by lifestyle modification or the intense statin therapy, bring it by half the risk, you bring his LDL cholesterol to 80 milligram per deciliter, you're going to have the 2% risk only at 8 years. That's extremely important. Or if you don't do that, at 60 years, he is going to have a 16% cardiovascular risk. That is what we know as of today. So the important take message I would like to say is that don't miss a chance to estimate the lifetime LDL risk for a child. So any blood sample taken for some other purpose, because non-fasting instead of just calculate the LDL level. And if your LDL cholesterol is 70 milligram per deciliter, your chance of having a cardiovascular risk is 1% by 40 years. That is by 70 years. That essentially means that is why that 5,000 number came. It will be differentiate between the cardiovascular risk and the cardiovascular event, and utilize any opportunity by therapeutic lifestyle changes to achieve that. Not, you should really think when to start the statins. And what we achieve by giving statins, if you are going to accept a LDL of 100 milligram per deciliter, you can think that you are going to get a 1% risk by 50 years. You are going to 125%, 125 by milligram deciliter, you are going to get a cardiovascular risk of 1% at 40 years. And if you are, that is what we have to think and decide as a recommendation. And thank you so much for the excellent presentation, Dr. Ravi.
Thank you very much, sir. Since the director has also become an actor, we will wind up this session. Thank you to both the speaker and the director for the excellent comments. We now come to the end of the first section of the anthologies. We have a 30-second break followed by the next session on caveats, which will be handled by my dear friend, Dr. Abhilash TG. Thank you very much.
From dilemmas, we move on to caveats. The first talk will be, how long should I really continue dual antiplatelet therapy after PCI? And the talk will be by Dr. Praveen Velapan, and the director will be Dr. Manindra.
Good morning, everybody. Respected chairperson, respected teachers, and my dear friends. For the next few minutes, we will be discussing on the duration for which we have to continue dual antiplatelet therapy after PCI. In these difficult corona times also, we should not forget that coronary artery disease is equally important, has to be tackled. A lot of people are approaching us with acute myocardial infarction. We are doing PCI with drug-eluting stents, and what all medications to continue. The debate always goes on about whether to continue the dual antiplatelet therapy for 3 months, 6 months, 12 months, or an extended therapy up to 30 months. So we'll see a small case scenario. Here we have a 63-year-old diabetic who was TMT positive, underwent PCI to RCA with 2 overlapping deaths 12 months ago. And he has been on dual antiplatelet agents for the past 1 year with no other complications, no bleeding, no GI symptoms, renal dysfunction with normal hemoglobin levels. So this is a typical patient who can present to us. And our dilemma is how much longer to continue the dual antiplatelet agents. So the optimal duration of dual antiplatelet therapy after PCI with drug-eluting stents still remain uncertain. Patients with severe coronary atherosclerosis are associated with adverse prognosis and obtain benefit from extensive dual antiplatelets. However, it is usually associated with a high risk of both short-term and long-term major bleeding. That is a trade-off between ischemic risk versus the bleeding risk. And for this, we have now 2 scores available. One is the DAPT score and another is the precise DAPT score. In precise DAPT score, a score more than or equal to 25, and in the DAPT score, a score more than or equal to 2 warrants a long-term dual antiplatelet therapy. So if you remember my case history, it was a 63-year-old. So age-wise, he gets a point of 0. He's a diabetic, so he has 1 point, and he has undergone a prior PCI. So he has 1 point. So he requires long dual antiplatelet therapy according to the DAPT score. And it is a class 2B recommendation to use these scores to evaluate the benefit and risk of different DAPT durations. So whenever a patient comes with stable coronary artery disease or an acute coronary syndrome, what we have to look is the bleeding risk of the patient. If the patient has no high bleeding risk, then definitely it's a 2BA indication to continue the dual antiplatelet therapy for up to 30 months. If there is a high bleeding risk, we can stop if the risk is if it is a bare metal stent, we can stop at 1 month. Drug-eluting stent, we can stop at 3 months and then continue on a single antiplatelet agent. Whereas in acute coronary syndrome, with no high bleeding risk, we can even think of continuing the dual antiplatelet therapy for more than 30 months. And with high bleeding risk, we have to continue at least for a duration of 6 months. So 3 or 6 versus at least 12 months DAPT duration. The 2 trials, as we know, were the Excellent trial and Prodigy trial. And these trials actually showed that shorter duration of DAPT is similar to a prolonged duration of DAPT following PCI. So why we are thinking about a shorter duration of DAPT? Because DAPT definitely increases the risk of bleeding, particularly in patients requiring a third drug, that is an oral anticoagulant. The longer you treat with DAPT, the higher the risk of bleeding. And current generation DES, as we know, have a very, very low risk of stent thrombosis. Thus, prolonged therapy may not be needed. And when is it safe to stop dual antiplatelets? If PCI is for stable ischemic heart disease, dual antiplatelets can safely be stopped after 6 months. Situations where longer therapy may be needed is a complex PCI or a prior stent thrombosis. And situations where a shorter therapy should be considered is those requiring oral anticoagulants and those requiring non-cardiac surgery and those at a high risk for bleeding. So this is the DAPT study, which was a landmark trial which enrolled 10,000 patients. And continued treatment with thienopyridine as compared with placebo reduced the rates of stent thrombosis, reduced the rates of major adverse cardiovascular and cerebrovascular events. MI was lower and the rate of death was from any cause was also lower. The rate of moderate or severe bleeding was increased with continued therapy. That is a trade-off that we were discussing earlier. So dual antiplatelet therapy beyond 1 year after placement of a drug-eluting stent, as compared with aspirin therapy alone, significantly reduced the risk of stent thrombosis and major adverse cardiovascular and cerebrovascular events, but was associated with an increased risk of bleeding. So guideline recommendation for duration of DAPT is usually for 6 months and up to 1 year. And if the precise DAP score is more than 25, then the DAPT for 3 months should be considered. So extended term dual antiplatelet therapy was associated with less MI in comparison with 12-month DAPT or short-term to mid-term DAPT followed by aspirin monotherapy after PCA with drug-eluting stents for acute coronary syndrome. So prasugrel and ticagrelor significantly increase the risk of TIMI major non-CABG related bleeds. So these data establish that the 1 year course of DAPT, preferably with prasugrel or ticagrelor, for patients undergoing PCA for ACS unless there are contraindications. And for secondary prevention of MI also, Pegasus trial, which recruited 21,000 patients, all patients were randomly assigned to ticagrelor 90 mg BD, 60 mg BD or placebo. Patients who continued their thienopyridine treatment without a major interruption derived a larger benefit from extended ticagrelor intake than patients who interrupted their thienopyridine treatment for longer periods of time. And so it is reasonable to favor ticagrelor 60 mg BD as the agent of choice for prolonging DAPT beyond 12 months in stabilized post-MI patients at a low bleeding risk, and to reserve the use of clopidogrel as the alternative choice if ticagrelor therapy is not tolerated or feasible. So for secondary prevention after MI also, meta-analysis showed that extended DAPT decreased the risk of MACE and there was benefit. This benefit was achieved at the cost of a significant increased risk of major bleeding. So in high bleeding risk, we have to decrease the duration of dual antiplatelet therapy to less than 6 months. But it is always associated with a trade-off of estimated increase in the risk of MI or definite or possible stent thrombosis from 1.7 to 2.4 compared with a 1 year DAPT. So consider discontinuation only if the bleeding risk is high. So what are the clinical implications? In comparison with a 12-month DAPT, the net clinical benefit appears to favor a short-term DAPT followed by P2Y12 mono inhibitor therapy instead of aspirin in selected patients, although extended term DAPT has a role for patients who have a low bleeding risk but with higher ischemic risk such as acute coronary syndrome. So what I personally feel is that we should have a personalized approach considering each patient's relative and absolute risk of ischemia and bleeding should be considered when deciding on the optimal intensity and duration of dual antiplatelets after percutaneous coronary intervention. Thank you.
Thank you, Praveen sir, for that excellent talk. And over to Manjuran sir.
Thank you. First of all, let me thank Sulfi for giving me an opportunity to talk to you. Am I audible?
Yes, sir.
No. I congratulate Praveen for his excellent talk. He has almost covered all the literature available. As he has rightly pointed out, the most important thing that we have to consider when we are considering near about the term, for example, let us say 1 year, whether to continue dual antiplatelets is based on the patient characteristics. Whether the patient has got a high risk thrombotic character or the patient is having a risk of a high risk bleeding candidate. So bleeding is more important. At the end of a year, thrombotic risk is actually given less importance compared to the bleeding risk. If the bleeding risk is high, then that patient better not to continue on a long-term basis. But if the patient's bleeding risk is very low, then there is a recommendation that this can be continued, dual antiplatelets can be continued for 30 months with some benefit. We must always remember that bleeding risk is a double-edged weapon. When the patient bleeds, we are in great trouble. We have to stop both dual antiplatelets. Sometimes we have to give blood transfusion, thereby making the blood more thrombotic. because when we give more blood transfusion, we are infusing new platelets. When we are stopping antiplatelets, the platelets formed from the patient's body itself is not loaded with antiplatelets. So there is a high risk of thrombotic complications. So that is a very important thing we should remember. Second thing is very interesting, that the patients, when they were discontinued on dual antiplatelets, for the first 3 months, in 2 studies, there was a higher incidence of thrombotic complications. The thrombotic complications may be at the site of stent implantation, or maybe from a progression of a lesion which was already pre-existing. For example, this patient has got 2 lesions, mild lesions in LAD as well as in circ, and these lesions can progress, and they can also contribute to an acute coronary syndrome other than stent thrombosis. So that can be another situation where there can be an acute coronary syndrome because of the progression of the lesion. That can also be looked after to some extent by dual antiplatelets. I want to ask one question to Praveen. Praveen, if the studies have shown that when you stop dual antiplatelets, there is a higher thrombosis during the first 3 months. Do you think that when you are stopping dual antiplatelets, you should taper clopidogrel, or whatever is the second antiplatelet that you are continuing? Do you think that you should taper it so that you can tide over the problem of thrombosis during the first 3 months? I'm asking a hypothetical question.
As you rightly pointed out, thrombotic complications are a risk once we stop the dual antiplatelet therapy. As far as I saw, there is no real recommendation as to taper down the antiplatelets and come down. But now recent studies say that continuing a thienopyridine like ticagrelor is better than continuing aspirin as a single antiplatelet therapy.
No, I'm not saying, I know there is no studies available. I'm asking you on your analysis, do you think that this may be a solution, that you can taper the clopidogrel? It is only a hypothetical question.
Yes,
I
sir,
agree
maybe.
with you that there is no literature available.
As you told, there is no study, but it may be reasonable.
Okay, I want to ask you a question. We have not answered
Sir,
what we should do for this patient. Just answer that.
According to the DAP score, this patient has a score of 2.
Yep.
So it warrants a long-term therapy. And as you told, there are minor lesions in LAD and circ, which can progress if once we stop the dual antiplatelets. So I will consider continuing the dual antiplatelets for an extended period more than 1 year for this patient, sir.
Okay, I also agree. This is a class 2B indication. It is
Yes.
not a strong indication, but it is a class 2B indication because he is a very low risk candidate for bleeding. But there is some degree to suggest that he has got a reason to continue dual antiplatelets. Thank you, Praveen. Thank you.
Thank you, sir.
Thank you.
Thank you, Praveen sir and Manjunan sir. We move on to second talk. We are running a little late. Which among my HCM patients should receive ICD for primary prevention? And the talk will be by Dr. Hisham Muhammad, and our director is dear Venugopal sir.
Good morning, everyone. And at the outset, let me thank the Csi Heart Shorts team for the opportunity to be a part of this digital event. And the clinical question that we'll be trying to address in the next couple of minutes is, who among my HCM patients should receive an AICD for the primary prevention of sudden cardiac death? The script represents a commonly encountered clinical situation where a young patient who is largely asymptomatic has presented with a diagnosis of hypertrophic cardiomyopathy of the obstructive type with no family history of sudden cardiac death. And the patient has considerable anxiety having encountered the term sudden cardiac death on a Google search. By looking at the clinical question that we posed ourselves a few minutes ago, what we are really trying to understand is, how do I risk stratify the SCD risk of an HCM patient in the context of primary prevention? And this is important because we know that HCM is the commonest cause of sudden cardiac death in the young, and it is the most devastating complication of the disease, to which the younger patients seem to be more vulnerable than patients in an older age group. At the moment, AICD implantation is the only form of therapy which seems to mitigate the SCD risk. And for these reasons, a comprehensive SCD risk stratification strategy is of paramount importance. A multitude of studies have looked at an array of clinical risk markers over the last few decades, and they have arrived at 7 major criteria of established clinical risk factors. The utilization of these 7 criteria have substantially reduced disease-related mortality by contributing to a comprehensive risk stratification strategy, and this approach has now been validated in the recent 2020 HCM guidelines. And as a result, now there is a very firm recommendation to perform a comprehensive, systematic, non-invasive SCD risk estimation in every single HCM patient at the initial evaluation, and to repeat such an evaluation at 1 to 2 year intervals. And this recommendation comes with a reasonable quality of evidence. The 7 major risk factors that we should be looking out for have been listed on the left-hand side of the screen, and amongst them, 3 of them have been novel additions to the guidelines. The presence of 1 or more of any of these 7 major risk markers have the potential to identify an HCM patient with an increased risk of sudden cardiac death in the future. And considering the cinematic theme of this meeting, one can think of these 7 risk factors as the Magnificent 7. And now, looking at each one of these 7 risk factors very briefly, we start off with the family history of sudden cardiac death, in which a sudden cardiac death attributable to HCM in a first degree or second degree relative of less than 50 years of age is a definite red flag. Multiple sudden cardiac deaths even in tertiary relatives should also be considered highly relevant. Coming to the extent of left ventricular hypertrophy, the maximum LV wall thickness of more than 30 millimeters has always been a traditional SCD risk marker. But the important thing to understand is that the numerical criteria for maximum LV wall thickness is not binary. It is, in fact, a continuum. This means that even in patients with LV wall thickness approaching 30 millimeters, it has to be considered as a significant risk marker. For example, in patients with LV wall thickness approaching 28 millimeters. In pediatric patients with HCM, we often rely on Z-scores of more than 20 or more than 10 in conjunction with other risk factors to characterize a particular child as having a higher risk for sudden cardiac death. Looking at unexplained syncope as a risk marker, the occurrence of a syncopal event, which is judged by history to be unlikely to be of neurocardiogenic origin or attributable to left ventricular outflow tract obstruction, these episodes are quite significant, and especially when these episodes have occurred within 6 months of evaluation. The presence of a remote syncopal event beyond 5 years of age does not appear to have the same prognostic relevance. An impaired ejection fraction of less than 50% is a novel risk marker. HCM patients usually start out with a supranormal ejection fraction, and any deterioration in the ejection fraction to this extent usually indicates an important transition point in the natural history of disease. And in the cardiac MRI of the patient shown here, you can see that there is an impaired left ventricular ejection fraction. A left ventricular apical aneurysm defined as a dyskinetic or akinetic segment is now considered to be a potent risk marker for sudden cardiac death in an HCM patient, independent of size. And in the patient example shown here, in this cardiac MRI image, you can clearly see that the left ventricular apical segments are thinned out and dyskinetic. The extent of late gadolinium enhancement to more than 15% of the left ventricular mass, representing fibrosis, has robust data supporting it as an indicator of sudden cardiac death risk. In the case example shown here, you can see the dense whitish late gadolinium enhancement in the following distribution. In the apical 4-chamber view, you can also see the gadolinium enhancement in the anterior and in inferior distributions in the 2-chamber view. And over here, you can see the corresponding distribution in the 6 short axis slices from the base to the apex. Sticking with late gadolinium enhancement, at our institution, we prefer to use a software matrix overlay technique in the post-processing to accurately quantify the percentage of late gadolinium enhancement. And the patient I've just shown you the late gadolinium enhancement was calculated to be around 28% of the left ventricular mass. Now let's take a look at NSVT runs and ambulatory monitoring as a risk marker for SCD in HCM patients. All the recent data and the guidelines seem to indicate that not all the NSVT runs in the context of HCM have the same prognostic significance. Over a period of 24 to 48 hour monitoring, NSVT runs which are more frequent, NSVT runs which are longer, more than 10 beats, and NSVT runs which are faster, more than 200 beats per minute. It is these NSVT runs which have the strongest prognostic significance in terms of a sudden cardiac death risk in HCM patients. When NSVT runs occur in isolation, these caveats must be looked into. However, when NSVT runs occur in conjunction with the other major 6 risk factors, these caveats may not be that significant. The integration of the risk factors that we saw in the previous slide into a risk stratification algorithm will look something like this. In the primary prevention context, we know the presence of any one of these major risk factors gives us decent evidence for an ICD implant for primary prevention. And we know that when NSVTs or LGE are considered on their own, we do have a certain level of decent evidence to contemplate an ICD implant for primary prevention, but we must remember their strength as prognostic markers are the strongest when they are combined with the other major risk factors. In children, we must note that the NSVT runs in children are of more prognostic significance than in adults, especially when the VT rate exceeds 20% of the baseline sinus rate in children. At this point, it is also worthwhile noting that genetic mutation-guided risk stratification at this point in time, in terms of evidence, is not a validated approach in HCM patients. A quick word on the alternative approach to SCD risk stratification HCM via the ESC HCM risk SCD calculator, which is based on a mathematical equation and which gives us a risk of SCD at 5 years in terms of percentage. There have been significant limitations which have been exposed of the ESC risk calculator, and over the last 2 to 3 years, there's been a significant body of evidence which has elegantly shown that the ESC risk calculating system has a low sensitivity in actually detecting HCM patients at high risk for sudden cardiac death. In summary, this updated and clinically validated ACC-AHA risk stratification system, along with the shared decision-making process, should be the roadmap for all of us clinicians in taking care of HCM patients. No risk stratification system is perfect, and the current system will continue to evolve as years go by. Thank you for your patient listening.
Thank you, Hisham, for that wonderful talk. Over to Venugopal, sir.
Thank you, Hisham. As usual, a brilliant academic talk. As the director, in filmy language that you are using as the director, the script has been so beautifully written that the director has only to follow the steps of the script. I do not think that I have anything else to add, but certain points I need to highlight. This particular gentleman has come with a great deal of anxiety. One thing that we could tell them that the risk of sudden cardiac death in HCM is not very high as we have thought. Risk is less than 1% per year. And it is in the younger patient population that the risk is much higher. Somebody who comes to you with an older age group, 45, we all know that their lifespan is almost the same as a person without any disease. So the young patient needs to be, as Hisham highlighted, the younger patients need to be evaluated for risk at least yearly or once in 2 years. That's a point which he has already highlighted, which I also would like to think of. The other practical point which I have been always discussing with Hisham is that we tend to use less of CMR in patients with hypertrophic cardiomyopathy, something which we need to look at. Any patient, a young patient who comes with hypertrophic cardiomyopathy should be subjected to a cardiac MR evaluation, not only for assessment of left ventricular wall thickness, but also as LGE. The second thing is that we need to know the genetic preposition for HCM. Even though it is said that the HCM is one of the most common genetically transmitted disease, 1 in 500. If you add genetics to it, actually the preponderance, the prevalence comes to 1 is to 200. Therefore, we need to look at the relatives of patients with HCM in a much broader way than we are looking at, because most of the people who come with sudden cardiac death in the young who have hypertrophic cardiomyopathy are absolutely asymptomatic, and do not have any symptoms of this thing. So this is another particular aspect. I think people like Hisham, who has been spending time in HCM, would be looking at these aspects of hypertrophic cardiomyopathy also in their future academic deliberations. I think all the factors that we need to look at, especially the LV aneurysm part, all these things have been really highlighted. So I don't think that anything else need to be. I just wanted to ask Hisham, in this particular patient, whether you have put an ICD. As far as I am concerned, probably I wouldn't put, but I just wanted to look at his opinion also. Thank you, Hisham.
Yes, sir. So I think this was a hypothetical script which was provided by Sargent. So in addition to the clinical data that this patient already has, I would completely agree with you, sir, that I would go ahead and put him through all of the systematic steps that we saw in the previous slides, including a CMR, LGE, a 24 to 48-hour ambulatory monitoring, and then try to arrive at a reasonable risk stratification procedure for this given patient. And I also would completely agree with you, sir, that the initial 8 to 10% rates of death per year, which were initially quoted for HCM, were from populations which are essentially hospital referral-based populations. And in fact, the actual event rates are much lower. But having said that, we should not shy away from a systematic approach for SCM risk stratification, especially in the younger patients and in older patients from a case-to-case basis.
Yeah, but I think your relatives, the patient's relatives also need to be screened, because they may be the ones who are coming with sudden cardiac death, fatal event, and which we could have prevented if we really go into their genetic makeup.
Absolutely.
So the echo may not show a hypertrophy in these patients. So I think that is again a point which we need to look at in future deliberations.
I agree.
Thank you, Hisham. Thank you, Venugopal sir. Moving to the last talk of this session, ICR in top. Does everyone live happily ever after? The actor is Dr. Deepa S. Kumar and the director is Dr. KK. Over to you.
Good morning, everyone. My story is that of a 16-year-old girl with tetralogy of Fallot. She has undergone repair at 2 years of age. She comes every year for review. She's asymptomatic. She's got a saturation of 97%. Her ECG is showing a QRS duration of 135 milliseconds, but echo is showing moderate pulmonary regurgitation with dilated right ventricle. So first, I will inform her that she's had a tetralogy of Fallot surgery and she has been repaired but not cured, and she needs to be on yearly follow-up. So what if you don't repair a tetralogy of Fallot? This is a natural history of tetralogy of Fallot. There is a survival of 64% at 1 year, but it falls rapidly to 4% by 15 years of age. So how did the surgery of tetralogy of Fallot repair progress? It progressed from an era of aortopulmonary shunt to staged corrective repair in the early 80s to the present day, which is an era of primary repair and transatrial repair. So are we there yet? Have we reached our final endpoint? So if you consider survival as the endpoint, 30-year survival of 90% has been reached with a re-intervention-free survival of 75% at 25 years. So if you want a happy ending, this is where you should stop your story. But of course, the story has to go on. And when we follow up patients with tetralogy of Fallot, we find that most of them have developed atrial or ventricular arrhythmias on follow-up with the risk of sudden cardiac death. Some of them may have peripheral pulmonary stenosis. Some of them may have aortopathy with aortic regurgitation. And some of them may have residual lesions like ventricular septal defect or RV outflow tract obstruction. They may develop LV or RV dysfunction. And most of them have pulmonary regurgitation on follow-up. They obviously have right branch block, which may progress and cause dysynchrony and biventricular dysfunction. Overall, these repaired tetralogy of Fallots have been found to have overall reduced lifespan when compared to their peers. 40 to 80% of all repaired tetralogy of Fallots have moderate to severe pulmonary regurgitation by 5 to 10 years. It was considered benign in the 70s to 80s, but now we know that it could be a wolf in sheep's clothing. Histology in early follow-up of repaired tetralogy of Fallot has shown RV hypertrophy, which may progress to myocardial fibrosis later in all those patients with pulmonary regurgitation. The worrying thing is that they have similar findings in left ventricle also. Exercise capacity may be preserved till late, so the patients may not be symptomatic until very late when you can't do anything for them. So unless corrected, they develop irreversible systolic and diastolic dysfunction. These are the indications for pulmonary valve replacement. So all those patients with the index end systolic volume of more than 80 or end diastolic volume of more than 160, or those who have at least moderate TR or with at least moderate RVUTO should undergo pulmonary valve replacement. Or isolated right ventricular outflow tract obstruction, which is severe and symptomatic, or severe and asymptomatic with any of these criteria should undergo a pulmonary valve replacement. This I know is quite a busy slide, but I just want to show you that once a patient has developed severely decreased LV or RV function, then pulmonary valve replacement may not do any good, and they are no longer considered good candidates for pulmonary valve replacement. So you should keep all these patients under close follow-up. Whoever has more than moderate pulmonary regurgitation, you should assess them by MRI. And if they fulfill the volume criteria for PVR, they should undergo pulmonary valve replacement. Or even if they don't fulfill these criteria, if they have sustained arrhythmia or residual lesions requiring surgical intervention, they should undergo a concomitant pulmonary valve replacement. 40% of all those repaired tetralogy fallow undergo pulmonary valve replacement by 30 years of follow-up. 75 to 90% of these undergo re-PVR at 10 years. Transcatheter PVR is a very good alternative to surgical PVR, especially for those patients with conduit repair. Hazard ratio for intervention in this subset is 0.4 to 6%, with a risk of infected enterocolitis of 2.3% per patient year. Certain patients with risk factors for ventricular arrhythmias like ventriculotomy, increasing QRS with those with transannular patch, ventricular dysfunction, RV scarring on MRI, all those patients are at risk of developing ventricular arrhythmias. If they are having monomorphic VT, they may be amenable for catheter ablation or concomitant surgical ablation if they are preserved by ventricular function. These should be done in centers with adequate expertise. In those patients with polymorphic VT, ICD may be indicated as secondary prophylaxis, and 5 to 10% of patients of tetralogy fallow repair on long-term follow-up ultimately require ICDs. But ICD as primary prophylaxis is still a controversial subject, and there has been a development of a risk score to consider those patients with higher risk score for primary prophylaxis, and these are the factors that are considered under the risk score. 4 to 20% of patients who have had repair of tetralogy fallow may develop atrial arrhythmias during their lifetime, most of which is intra-atrial re-entrant tachycardias, and they appear 10 to 15 years after surgery. Most of them are effectively treated by catheter or surgical ablation. Medicines are not very effective. Increasing QRS width have been shown to have adverse atrioventricular, interventricular, and intraventricular interactions leading out to dysynchrony. CRT has been shown to have some benefit in this subset of patients. So this 16-year-old girl will come to you later and she will ask you, will I be able to undergo pregnancy and delivery? We have to inform her that her risk is low, especially in patients with good hemodynamics and in patients without significant residual lesions. But if she has severe PR at the time she's planning pregnancy, she should undergo cardiac MRI for assessment of RV volumes and function. And if she satisfies criteria for PVR, she should undergo pulmonary replacement prior to planning pregnancy, as pregnancy may precipitate arrhythmias or right heart failure. But the bottom line is that pregnancy is unlikely to have an adverse long-term effect on cardiovascular function in most of these patients. And the next query that she will have is, will my child inherit my heart disease? Generally, tetralogy fallow is not a heritable disease. Recurrence risk is, if one parent is affected, is only 4% for the next child. If one sibling is affected, the risk is 2.5%. If two siblings are affected, the risk increases to 8%. These mutations that I've written below, they have slightly higher chance of inheriting a heart disease like tetralogy fallow. So if a person has been screened and found to have one of these mutations, they should be counseled that the child may have a slightly higher risk of contracting the disease. Tetralogy fallow with syndromes constitute 20% of all tetralogy fallow patients, of which the commonest is trisomy 21. 22q11 deletion is seen in 16% of all tetralogy fallow. So that is Pandora's box. In that you find that there are a lot of anomalies, not only congenital heart disease, especially those pertaining to adulthood like schizophrenia and psychiatric disorders, immune disorders due to reduced T cell numbers. So if you find a 22q11 deletion in a patient with tetralogy fallow, they have to be counseled that they may face certain problems later on in life. These are the good guidelines for follow-up of a repaired tetralogy fallow. As you can see, they have been developed in physiological stages A to D. Physiological stage A corresponds to those with NYHA class 1 and stage D corresponds to NYHA class 4. So as you can see, stage A, you need not follow them up so frequently. They can be kept on yearly or 2-yearly follow-up, but even they need every 3-year MRI and exercise testing every 3 to 5 years. And as they go up they go into advanced physiological stages, they need much more frequent follow-up, and they need MRI as closely as 1 to 2 yearly to pick them up if they are candidates for any intervention like pulmonary valve replacement. So will I tell my patient that she will live happily ever after? But I will not tell that, but I can convincingly tell her that she can live happily even after. So this is not the end of her life, it's just the beginning of a new life. Thank you.
Thank you, Divya madam. Over to Krishna.
So I said, I'm not so sure about how I can serve as a director. As Dr. Venugopal previously said, Deepa actually has clearly outlined a lot of things, but I think I want to clarify a few things and perhaps dispel a few myths. It's important to understand that one, all those criteria that we have listed is not evidence-based. Remember that 150, that 80, all those numbers have no evidence base. They are a consensus criteria that was put together and it's appeared in an editorial written by Tal Giva. Everybody likes those criteria. It makes intuitive sense. There is no science. There is just a general feeling that, okay, that might work. So we don't need to be so supremely rigid. So we seem to have created a very nice protocol of doing MRIs. When they meet those volumes, we very respectfully recommend on basis of those volumes. But remember, all that is just based on expert consensus, not any opinion. I don't remember this 1A, 2B, 3C, but this is one of those, 2C, whatever, 2B, something like that. Expert consensus, no evidence. But we don't have anything better, so we seem to follow it. I think it's our job to try and generate something better. The only basis on which those numbers happen is because the fact that if you do it before that 150 happens or before that 80 happens in systolic, then the chances are that the RV function is preserved. So this is the first myth. The second myth, very, very important. Pulmonary valve replacement does not prevent sudden cardiac death. No study has shown. In fact, studies have shown no benefits of pulmonary valve replacement in prevention of sudden cardiac death. So interestingly, there's a lot of work done in the Netherlands centers and in few other centers. The substrate for occurrence of ventricular tachycardia is often in the right ventricular outflow tract. Sometimes that substrate is hidden by pulmonary valve replacement. So if you replace the valve, you may not actually have access to that substrate. So it is extremely imperative to understand the propensity and the risk for sudden cardiac death, perhaps define that substrate, eliminate it if possible, and then consider pulmonary valve replacement. That is perhaps the reason why pulmonary valve replacement is not making such a difference. It's too simplistic to think of that one procedure to make the difference because the mechanisms of sudden cardiac death, of progressive ventricular dilation are all quite complex in the substrate. What is important is if this patient comes today, this happened in a 16-year-old who came to you. But if this patient comes today, we have a different picture altogether emerging. Our surgeons, I'm sure it happening in Chitra, it's happening in Amrita, endeavor very much to try and preserve the pulmonary valve. So the whole approach to tetralogy has altered dramatically, and the surgeons now work towards avoiding the transannular patch, respecting the right ventricle, trying to minimize the substrate for future development. And I think that's a very, very welcome trend. And today we may have to say something slightly different from what we could say some time ago. Today we would still be cautious. We'll still say you need lifelong follow-up. We cannot rule out future surgery. You need to be under regular visits. We need to be a little cautious and not give them a clean chit. But at the same time, we are far more optimistic today than we were 15 years ago.
Thank you, Krishna sir and Diva madam. And this session is
Can
over.
Deepa not respond to what I said?
No, sir. I genuinely want your opinion on whether we really should follow these volumes, because you know that we have missed patients who have really developed RV dysfunction, who we didn't really monitor by MRI. So.
No, I agree, but the point is it's not sacrosanct. That's the point I wanted to make.
Okay. Thank you, sir. Thank you, Diba madam. The next session is on controversies. Will be after 30 seconds.
Thank you very much, Abhilash. Now we go to the last section, Anthology 3 on controversies. The first topic is what dietary advice do I really need to offer to my CAD patients? To speak on this, we have Dr. Vinod Manikandan, a very young and energetic and I would say sporty actor. And we have an expert in the field as a director, dear Dr. Giver Zacharias. Over to you, Vinod. Can we have the talk by Dr. Vinod, please?
Yeah. Good morning, everyone. When we talk about a healthy heart, the diet becomes an integral part of our daily routine. Poor diet is one of the commonest risk factors for cardiovascular disorders. So much controversy surrounding the optimal diet and cardiovascular health. So, in the next few minutes, we will talk about some controversies about dietary recommendations in the that exist in the public as well as in the media live dates. So, our patient is a 13-year-old doctor who are an angiography who are underwent PTC to LAD. If we have dyslipidemia and he has family history of diabetes, he prefers non-vegetarian diet. So, what would be the ideal dietary advice for the secondary prevention of cardiovascular disorder? That is the scenario here. So, to summarize the recent developments in the nutrition and cardiovascular health, we have 2008 dietary guidelines revision, which have guidelines for general population as well as those with the cardiovascular disorders. For general population, they are advised to consume more amount of fruits and vegetables, consume grain products including whole grains. Fat should be less than 30% of the total energy, limitation of dietary saturated fat less than 10% of energy, and cholesterol to less than 300 milligrams per day. A limit salt intake to less than 6 grams per day, to consume at least 7 grams of omega-3 fatty acids, and supplements like carotene, vitamin E, vitamin C, and folic acid are not recommended. Guidelines for individuals with pre-existing cardiovascular disease. The upper limit for such individuals is less than 7% of total energy for saturated fats and less than 200 milligrams of cholesterol per day. So, increase the consumption of vegetables, fruits, legumes, nuts, whole grains, and fish. Increase mono and polyunsaturated fats and complex carbohydrates. Reduce the consumption of processed meats, refined carbohydrates, sweetened beverages, saturated fats, trans fats, cholesterol, sodium, and simple sugars. But the patient plan should be based on socioeconomic circumstances, cultural influences, and individual health factors. Between vegetarian and non-vegetarian diets, which one is better? As you all know that plant-based diets have definite cardiovascular benefits, but vegetarian diets have pros and cons. The pros are it contains high amount of vitamins and antioxidants. It has high level of fiber and phytonutrients, less amount of cholesterol and saturated fats, but it is deficient in vitamin B12 and lack protein, omega fatty acids, selenium, iodine, and zinc. Vegetarian diet is a boon or bane for health. Vegetarian diet is a boon to health for no doubt, but if the diet is not planned properly, it may be proved to be bane to the health. So those who follow vegetarian diet make sure that they consume adequate amount of proteins, minerals, and vitamins along with it. Rice for staple diets. So between brown rice and white rice, which one is better? Brown rice, being a whole grain, it contains outer fiber band as well as subballoon layer in addition to white rice. So it may help to reduce cholesterol and lower the risk of stroke, heart disease, and type 2 diabetes mellitus. Hence, it might have an advantage over white rice by offering protection from high BP and atherosclerosis. But remember, one thing, white rice consumption has not been shown to increase the risk of cardiovascular disease. So brown rice has cardiovascular benefits, where white rice has not been shown to increase the risk of cardiovascular disease. So we can prefer brown rice or white rice. Between red meat and chicken, as you all know that red meat contains so much of saturated fats, and not only that, the red meat, when it undergoes digestion, it produces a chemical known as dimethylamine N oxide, which can increase the atherosclerosis as well as clot formation in the arteries. So avoid red meat as far as possible. For those who cannot avoid, try to restrict the intake of red meat to less than 350 grams per week. And when you use chicken, remove as much fat as you can before cooking. Use healthier cooking methods and choose non-fried poultry without skin. And the maximum amount is 5.5 ounces or about 150-200 grams per day. Eggs and heart disease. The recent studies, cohorts as well as meta-analysis shown that moderate egg consumption, that is up to 1 egg per day, is not associated with the cardiovascular risk, and it is associated with the potential lower cardiovascular disease risk in Asian population. So even if you are a diabetic or dyslipidemic patient, or you have CVD, you can consume 1 whole egg per day, provided that you are not consuming much of saturated fat and trans fatty acid from other sources of food. Regarding fish and cardiovascular health, there is no controversy regarding this one because, as you all know, fish contains so much of omega-3 fatty acid, which have potential benefit when it comes to cardiovascular health. And the recommendation of omega-3 fatty acid is about 5,500 milligram per day for primary prevention and about 1,000 milligram per day for secondary prevention. At least 2 servings, that is 175 grams per week, are recommended. Oily fish like salmon, tuna, sardines, and cod are the best source of omega-3 fatty acids. Choose your cooking oil wisely. Opt for those which contains MUFA and PUFA. Use different types of oils every month for added benefits. And the total oil consumption should not be more than 15 ml per day. Regarding dietary fats and cardiovascular disease, do we really need to be concerned? The answer is no. The low-fat dietary products are already in the recommendations, as we all know that it has been found to be beneficial for the cardiovascular health. But regarding high-fat dietary products, even though it contains high amount of saturated fatty acid, their consumption induces a positive or neutral effect on human cardiovascular health, as it contains higher amount of nutrients and vitamins. So the native image of milk fat is weakening. So a patient who do not have any risk factors or cardiovascular disease can consume high-fat dairy products, whereas for the secondary as well as primary prevention of cardiovascular disease, low-fat dairy products are recommended. Coffee or tea, how much is too much? Moderate consumption of coffee and tea, or tea, that is about 4 cups of coffee as well as 3 cups of tea per day, is safe for most of the healthy adults. Either 4 cups of coffee or 3 cups of tea per day is safe. That's the maximum limit. And tea and coffee consumption have been found to reduce cardiovascular mortality as well as morbidity. Now avoid junk food as far as possible because it contains high amount of sugar, starch, and saturated fat, which can lead to hypertension, obesity, CAD, and heart failure. When it comes to snacks, avoid fried items like vada, banana fry. Then avoid white bread, biscuit, pizza, noodles, Cheetos, and kurkure. Replace them with steamed brown rice products, balsan, korakata, sprouted pulses, chundal, steamed banana, or steamed tapioca. Avoid frozen desserts, soft drinks, colas, added sugar drinks, and tin fruit juices, and replace them with samhara, boiled water, lime juice, or tender coconut water. And so far we have been mentioning about food and its effect on cardiovascular health. And based on that, I have made a sample diet chart for the index patient. The morning he can consume about 5 to 6 almonds or 45 walnuts with a glass of warm water. The breakfast he can have 1 cup of upma or 1 cup of oatmeal, 2 idlis or 2 dosa or 2 chapatis or 2 slices of brown bread. Along with that, he can have 1 glass of milk and 1 whole egg boiled or 2 egg white omelette. The mid-morning or along with the breakfast, he can have 100 grams of seasonal fruit and 1 glass of tender coconut water. The lunch, he can have 1 medium bowl of brown rice or vegetable pulao or 3 medium-sized chapatis plus 100 grams of chicken or fish plus 1 bowl of mixed vegetable salad or 1 medium bowl of curd. The evening snack, he can have 1 cup of green tea, bar coffee, bar lemon juice, bar mixed fruit juice, bar samvara, and small bowl of sprouted pulse or steamed tapioca or 1 korakata or balsan. The dinner, he can have 1 bowl of whole grain upma, 2 wheat dosa or chapati, 2 chapatis, plus 1 bowl of sambar, cooked dal, plus 1 glass of boiled water. The take-home messages are: match energy intake to energy needs, include a lot of fruits and vegetables, prefer complex carbohydrates over refined grains, moderate egg consumption is not associated with the cardiovascular risk, avoid processed meats, sweetened beverages, and red meat. Dairy fat consumption induces a positive or neutral effect on human cardiovascular health. Nuts are good for heart. Non-fried seafood 1 to 2 times per week associated with cardiovascular benefits. Thank you.
Dr. Vinod? Yes. Luckily, we are not serving lunch during the meeting, so there won't be controversies. Over to you, Giver sir.
Okay. Thank you, Vinod. I mean, you have covered the topic fairly extensively. But after reading the recent literature and my personal experience, I have felt that cardiologists for a generation have mistreated our patients regarding diet, because we have been saying that people, with the moment the people as a heart disease, we tell them no fat, no beef, no mutton, no eggs. And we all the no's and all put together actually frightens them more than the heart disease per se. People are frightened because they are looking at a future very bleak, and when they are denied of anything. Now, even Praveen Manikandan is saying 350 gram of beef per week. I think in Kerala, most people, take 85 gram of beef per week. That is the maximum they take generally. I am not talking about. So I think we have been guilty in denying our patients, very high protein, nutritious diet and asking them to go for a very high carbohydrate and very low fat and low protein diet, which probably is, I think, maybe harmful and maybe may not be a good idea. Now, all the studies have shown that the only secondary prevention study, the Mediterranean, the Leon Heart trial showed that, they had a 35% fat intake there in the diet, and there was no change in the calorie and the LDL cholesterol between the treatment arm and the control arm. Yet, they produced a 70% reduction in the event rate. That was a pre-statin era, of course, but I think the message is very clear. Now, we should not frighten our patients. We should instead talk about the dietary pattern, which Dr. Vinod has highlighted properly. What I tell my patient is, you take, I divide all the foodstuffs into very favorable, very unfavorable, and neutral. And then very favorable, I emphasize. I talk about 200 grams of fruits, 200 grams of vegetables, nuts, seeds, and legumes, beans, peas, fish. And so these are all good things which they can eat fairly in abundance. And the bad things they should avoid is all these snacks and biscuits and bakery items and the added sugar. They should definitely avoid. But that is not a very big deal for them. But regarding the eggs, I think there's a good news now. You can take eggs because we are protein deficient. The only study which I could find from all over India in the National Nutrition Board study regarding the calorie intake and different kind of food in India in 2005. And that study showed that an average carbohydrate intake of total energy is 80% in India. The fat is 10% and protein is 10%. This is grossly insufficient because, even in Kerala, the average carbohydrate intake in Kerala is around 70 to 75%. But the Indian dietary guidelines recommend 40 to 60%, 50 to 60% energy from carbohydrate. So I think we have gone wrong and it is time to set things right. So we should encourage people to reduce their carbohydrate intake and also increase even a little bit more fat is okay, provided it is confined to less than 10% of saturated fat. So we should encourage about other fat food to supply monounsaturated and polyunsaturated fat like fish, soy protein, olive oil, and even other oils also. There's no need to restrict too much of oil because already our fat intake is fairly very low. So I allude to that circulation article by Muzaffarian in 2016. He broadly divided into areas where no controversy, areas where partial controversy, areas there is insufficient evidence, and areas where is substantial controversy. So the areas where no controversy is beneficial effects: fruits, non-starchy vegetables, nuts, seeds, legumes, yogurt, dietary fiber, potassium, moderate alcohol, Mediterranean diet pattern, all are proved to be beneficial. Harmful is partially hydrogenated oil, processed meat, high sodium, sugars, sweetened beverages, food rich in refined grains and added sugars. And no effect, they specifically mention total fat. So total fat has no very harmful effect and no effect. So there is no harm in allowing total fat. So I think any comments, Vinod? This must be the diet everybody now recommend to all our patients. Yeah.
So that we should restrict the intake of carbohydrate to about 50% of the total energy intake. That is one message. And we can consume fat as much as 30% of the total calorie.
Exactly. When you ask the patient to reduce the fat, what happens is his carbohydrate invariably goes up. And carbohydrate is one area which which will not give satiety. So you keep on eating, and that is the one point you have to remember, that the ideal body weight, achieving the ideal body weight probably is the most important dietary advice we can give. And I recommend a BMI of 22. What do you recommend?
BMI will be somewhere between 20 or 23. That's my recommendation.
21 to 23 is the normal weight according to the Asian definition. So
yes.
More than 23 is overweight and more than 25 is obesity. So 21 to 23, but I just cut it and make it 22 and then create an ideal body weight for each patient and then tell them accordingly.
Thank you. Thank you, sir. Thank you, Vinod, for your comprehensive review. I still remember sharing a lot of meet along with you during our MD days. And thank you, Giver sir. Your words have reassured many of our the people in the audience. They are very happy. We are receiving comments that it is very reassuring to know that people can eat more. Thank you, sir, for your excellent comments. Thank you. We now go to the next talk. The topic is, how long should I anticoagulate my DVT or pulmonary embolism patient? Always a vexing issue when it comes to stopping. We have Dr. Krishna Kumar P, an actor from Trivandrum, and we have the Master Director, Dr. Ashokan Nambiar C, to look over the proceedings. Over to you. Can we have the talk by Dr. Krishna Kumar P?
Hello, I'm Dr. Krishna Kumar P, Associate Professor of Cardiology at Trivandrum College. The topic is, how long should I anticoagulate my DVT or pulmonary embolism patient? So venous embolism consists of DVT and pulmonary embolism, and we've got transient, persistent, unprovoked DVT risk factors. And VT in the COVID era is very significant. And diagnostic management of patients with suspected DVT, of course, is very important. And suspected pulmonary embolism and COVID patient has got a low threshold and should be maintained in the ICU setting. And coming to the duration of therapy, you've got initial management, primary and secondary prevention. Anticoagulation, of course, you've got the VKs, the NOACs, and parenteral drugs like heparin. Anticoagulation, of course, according to guideline, the NOAC has got class 1 indication. And parenteral anticoagulation include unfractionated heparin, low molecular weight heparin, and fundaparinux. Chronic treatment, of course, all the patients should receive more than 3 months of anticoagulation treatment, and extended anticoagulation can reduce the risk of VT by more than 90%. A lot of terminologies in this particular context. Venous embolism risk categories are divided into low, intermediate, and high, and a very strong indication, in fact, only for second unprovoked VT according to the ACCP guidelines. Risk factors, you have to think of whether it is transient or persistent. Active malignancy has got a recurrence of around 50-20%. D-dimer level is not routinely measured. Less validated risk factors like male sex, pulmonary embolism, of course, versus DVT. In fact, DVT tends to recur as DVT and pulmonary embolism as pulmonary embolism. And you have to consider longer duration of anticoagulant treatment after pulmonary embolism than after DVT. Residual vein obstruction and Doppler study is not routinely done except for finding out whether the clot is resolved or not, the vessel is patent or not. It's not routinely done for follow-up. And miscellaneous increased thrombin generation, sleep apnea, PTSD, reactive protein, and so on. Clinical prediction rules, you've got the HER2 rule, DAS score, etc. Rate of bleeding stratified by risk in patients with venous thromboembolism based on anticoagulation. And we've got the VT bleed, it's got 6 risk factors. ACCP model has got 17 risk factors, ACCP model. Patient values and preferences are also very important. In fact, again, I've got the estimated risk score recommendations. High recurrence risk for patients who have more than one episode of unprovoked proximal DVT and symptomatic pulmonary embolism, and more than one episode where unprovoked recommendation is indefinite. It's a class 1B indication. And patients with VT who have had active cancer as candidate for indefinite anticoagulation. For most of the patients with first episode of unprovoked proximal DVT or symptomatic pulmonary embolism, indefinite anticoagulation therapy is a class 2B indication. Now, coming to subgroups, like, for example, females with unprovoked VT and low DAS score, probably you can consider avoiding anticoagulation. Intermediate recurrent risk and any acute thromboembolic event with persistent non-malignant risk factors, low threshold for indefinite anticoagulations to be considered in patients who develop VT with transient minor risk factors. Extending the anticoagulation therapy is based on the observation that development of VT in this population actually may, particular population, there is a hypertoxicity. Low recurrence risk, class 1 indication. In fact, for patients with the first episode of VT provoked by a major transient risk factor, you can consider anticoagulating therapy for a finite course. Now, you've got prothrombotic conditions, which can be divided into major conditions and minor thrombophilias, and manage accordingly. Recurrent, provoked, and unprovoked proximal DVT and symptomatic pulmonary embolism, you can consider indefinite anticoagulation. It is coming vice versa also. Isolated distal deep vein thrombosis, optimal strategy is unknown, but a small proportion of the patients may benefit, and recurrent unprovoked distal DVT is an unusual scenario and may require anticoagulation for a longer duration. And provoked distal DVT, patients with isolated provoked distal DVT are not typically anticoagulated indefinitely. Incidental small subsacral pulmonary embolism without identifiable risk factors in CTPA, selected cases may be anticoagulated. Agent selection, of course, at the drugs, so you got the aspirin and warfarin, aspirin 2C and warfarin 2B indications. Aspirin routinely is not recommended. Others are low molecular weight heparin, fundopharinox, and not used most of the time. Silodexide, glycosamine glycan, that has been coming up, is not available right now. You got the drugs, a lot of studies recover Einstein amplified Hokusai studies with drugs, and the rate of venous thrombosis almost our annual rate after first year is halved compared to the first year. Other factors are subtherapeutic anticoagulation, malabsorption, discontinuation for an anticipated procedure, poor complaints, high dose requirement of heparin, and so on. Ongoing prothrombotic stimuli is also very important. And overall, the expected risk for recurrence is around 3% per year. And pregnancy, of course, at least 6 weeks postpartum, a continuation is recommended by ACCP. And you got extended therapy for VT, reduces the recurrent VT. A lot of studies amplify Einstein, resonate, fast, and so on. This is a guideline management. Upper extremity DVT, thrombophilias have been associated, and of course, you have to rule out inadequate thoracic outlet decompression. And of course, thrombophilia workup is important in selected cases, especially heritable thrombophilic defects. Cancer patients, low molecular weight heparin as a monotherapy can be continued in selected cases. Extended duration, I got Einstein choice study where roxaban low as well as 20 milligram dose has been found to be equal to aspirin in the superior to aspirin for prevention of recurrent VT, while the bleeding complications is the same. In the COVID era, of course, you've got rivaroxaban 10 milligram once day as prophylactic dose, and therapeutic dose is 10 milligram BID. And the thromboprophylaxis is important in COVID patients because of the high cumulative incidence of thrombosis, 2.5%, and VT 0.6% in post-discharge cases. Based on individual patient characteristics and laboratory parameters, patient-specific treatment modalities should be tailored, and clinical decision-making should be guided by current guidelines, risk assessment scores, and data from randomized controlled trials. Thank you.
Thank you, Dr. Krishnamur. Over to you, Ashwin Nambiar, sir.
Thank you, Abhilash Shisha and Dr. Sulfikar, for giving me this opportunity. So the main question here is, after the screenplay was gone through in detail, is when to stop. That's what I understood. I'm reminded of one of my old teachers saying that it's any fool can start an affair, but only the wise man knows when to stop it. So perhaps anybody who can tell us when to stop would be a wise man. But I fear I am not one of the wise men in this group. So I will make an attempt in advising this patient when the anticoagulation should be discontinued, or should she continue it indefinitely. Now there are some criteria for long-term anticoagulation. Before that, the short-term treatment is easier. You give treatment for 3 months. That is a management for an acute course, whether it is deep vein thrombosis or pulmonary embolism. At 3 months, most people should be stabilized. After that, there will be a subgroup of patients who may require a longer period of intervention. If you cannot stop at 3 months, many authorities like the European Society of Cardiology say there is no logic in continuing further. If the patient is having an ongoing risk, you continue. If it is treated properly, you stop at 3 months. But this patient already had treatment for 6 months. So I suspect that they had discovered some risk factor in the patient. We do not know really whether it is a proximal or a distal vein involvement. I presume that it's a proximal involvement. That's why they continued for 6 months. Now at this time, how do we proceed further? There are so many guidelines and risk factors around. But as practical persons, we go by our experience. We look at the patient as a whole. This is a 52-year-old lady. Not many risk factors are described. So the only question is, there is a deep vein thrombosis and there is some ongoing swelling and ultrasound shows still a thrombus with recanalization. So these are factors which we know. Unless the patient is having a thrombophilia or cancer or some other factor which you suspect, like a prolonged bed rest, multiple fractures, etc., then definitely these are candidates for long treatment, indefinite or long-term anticoagulation. We know that. On the other hand, if there are intermediate risk factors, like in this patient, presumed proximal deep vein thrombosis with a residual thrombus, I think there is a good reason, good logic to continue anticoagulation for some more time. I would definitely continue for 1 year and reassess the patient. Some experts suggest doing a D-dimer after discontinuing anticoagulation after 1 month, but this is not universally agreed upon. In fact, the ESC does not include it as a criteria. It is up to the treating physician whether to do a D-dimer or not. But in general, after one year, we can reassess the patient. If there is a bleeding risk, this is the main deterring factor. If there is a bleeding risk, while on treatment the patient develops a significant bleeding or develops another intercurrent illness or some factor which we understand will put the patient in excessive bleeding, like an abnormal liver function or abnormal renal function, or by chance the patient also develops a cancer or something, then of course at that time we should discontinue anticoagulation. Till that time, till there is anything particular to stop us, to deter us, I would consider definitely for 1 year, and sometimes if on reassessment she still continues to be in the intermediate or high risk category, there is no harm in continuing long-term anticoagulation. Many of these guidelines were prescribed when vitamin K antagonists were used as anticoagulants. They had considerable bleeding risk, like warfarin is 3% per year. Now with the newer correct anticoagulants, the risk is 40% of that of warfarin. That will come to around 1.2 to 1.5%. So this is not a very high risk. On the other hand, if by chance the patient develops another thrombotic episode, which is pulmonary embolism, the mortality is going to be about 30 to 40%. So we do not want to put the patient in undue risk. So if the patient can accept a newer oral anticoagulant, the patient is already on rivaroxaban, I will reduce the dose of rivaroxaban to 10 milligrams once daily, since the patient has already completed 6 months of treatment. I will continue it, at least for 1 year, and perhaps indefinitely, but with frequent reassessment of the risk factors and the clinical condition. That's what I want to say at this moment.
Thank you very much, sir, for your comprehensive directorial approach to the problem. And thank you, Dr. Krishnakumar, for your excellent review. Thank you. We now go on to the last topic of the day. The question is, should I treat subclinical device-detected atrial fibrillation? And we have yet another handsome protagonist, Dr. Abhilash SP, and we have the much respected and dear Tharagan sir as the director. Can we have the talk by Dr. Abhilash SP, please?
Good afternoon to my beloved teacher Tharagan sir and everyone involved online. I'm given a topic of subclinical atrial fibrillation, whether to treat or not. I would like to thank the organizers for giving me this opportunity. Let me go to the topic. The brochure of the conference program carried this impressive statement. A story should have a beginning, a middle, and an end. but not necessarily in that order. That is good. But in clinical medicine, I think should be still in a particular order. That is history, clinical examination, and investigations. Never in any other order. So we'll go back to our history that is given to me. 74-year-old lady, hypertensive, occasional giddiness, no palpitations. ECG showed only sinus rhythm. Echo is probably unremarkable except for a LVH and LA mildly dilated LA. Holter report, that is our question here. Sinus rhythm, intermittent sinus bradycardia, 6 short runs of atrial fibrillation with fast ventricular rate. She is not very much symptomatic, but we noted short runs of AF. I wish I had more details of this AF. How's the burden? I agree that 6 short runs, but still how short it is, the duration of AF. Why it is important, we'll come to know. In thyroid is normal, that is important. I'm happy to see that data. We need to learn a few wordings, AHRE, SCAF, SCAAT. These are SCAF and SCAT are interchangeable, AF and AT, that's all. But what is AHRE? Atrial high rate events. Many of our patients have a pacemaker on ECG implanted. So the device may detect an atrial fibrillation. That the device will tell us there's an atrial high rate event, AHRE. But that is not actually, we cannot imply that it is subclinical atrial fibrillation. It could be an oversensing. It could be a noise in the system. So we need to review the intracardiac electrocardiogram. Once we review and confirm that it's atrial fibrillation, we call it a subclinical AF. So this is what the machine tells us. This is our impression based on what is the information given to us. So is this such a big issue? To be frank, yes. The thing is that the tip of the iceberg, what we see is the clinical atrial fibrillation, which is actually documented in a 12-lead ECG or in a Holter where we can review the ECG and confirm that it's an atrial fibrillation. Not the Holter report like just we got it. We need, if we can see the tracings, even Holter can be taken as critical. 12-lead ECG, symptoms, and all our clinical management algorithms currently available are all based on this clinical AF. Even charts to VAC scoring, everything is for the clinical AF. But we have a bigger lot of subclinical AF, incidental finding, or when observed for something else, or it could be detected even part of ESUS evaluation. ESUS is embolic stroke of unknown source evaluation. Or it could be as simple as detected by a smartwatch. This is very common nowadays. So it can be, the subclinical AF could be detected by a smartwatch or an ELR or a Holter or implantable, an invasive thing like a pacemaker. So many ways the patient can come to us with this subclinical AF. This we can understand how it records an AF because it has a lead. This also we know it directly records how a watch can detect. There are certain complex algorithms in each watch which will calculate depending on the ECG, the rate. For example, this is a Lorentz plot used in one of the smart watches. Sinus rhythm will look like this. Lorentz plot again scattered in the watch will tell us that it's AT or AF, and premature atrial complex like this. So it is possible to identify subclinical AF more easily than previous days nowadays. But the problem is we need to confirm. Once you see in a device, we need to take the Holter or a 12-lead ECG to confirm it. Is it such a gray zone and dark area? No. Actually, we have multiple studies starting from 2002 to even now, who are studies ongoing. Of which just concentrate on this ASSERT trial, which was the largest trial, which included patients with pacemakers and ICDs, which showed us an AHRA, age more than 65 years, history of hypertension, but no history of clinical AF. And atrial rate was 190 and more than 6 minutes of an atrial high rate event was considered significant. They followed up to 2.5, not 2.5, then further went up to even 4 years, 5 years. Then we have data coming from certain studies, Embrace, Crystal, and again another ASSERT, which specifically looked at the embolic stroke of unknown significance. So from these studies, especially the ASSERT trial, give this important data. This y-axis is cumulative event rate, x-rate is years of follow-up. No subclinical AF is this blue line, and red line is 6 minutes to 6 hours, green line is 6 to 24 hours. They all had a similar event rate on a 3.5 year of follow-up, whereas an AF lasting more than 24 hours had significantly worse event rates. So that was an important message we got from the ASSERT. Then does that mean the between 6 hours to 24 hours is totally benign. When we looked at the other data from the different studies I quoted, it shows that for 10 minutes, the hazard ratio is around 2, whereas for 1,000 minutes of atrial fibrillation, it comes to around between 3 to 6, around say 4. So the duration is also important. These trials also gave us this information. Initially, you can see that the blue is less than 1 hour, 1 to 6 hours, 6 to 12 hours, 12 to 24 hours. That means even we are subdividing it into those atrial fibrillation within 24 hours. On follow-up of 36 months, you can see the incidence in each particular cohort goes up. So they are more prone to development of atrial fibrillation, clinical atrial fibrillation on follow-up. Another important thing which I want to bring your attention is AF. A thought is, we know this part of it. AF causes stroke. We treat this to prevent the complications of atrial fibrillation, anticoagulation, everything. But AF could be a marker as well, just like diabetes, dyslipidemia, vascular disease. So treating this just a paroxysmal AF as a disease, as a marker, by treating other diseases, you may even bring down the incidence of atrial fibrillation. Or rather than treating the atrial fibrillation, treat the associated diseases. This will be the current evidence for it, or the recommendations. You score. Remember that Shartsu VAC score is for clinical AF. We are trying to extrapolate. Score 0, score 1 for men, 2 for women, and more than 2 and more than 3. This is actually the classical indication for anticoagulation. So see this, and based on that, a very short high rate atrial event, nothing to be done in any Shartsu score. If it is 6 minutes to say 5.5 hours, we have, it's a great zone now. So we have 2 trials currently going on in this group. That means 6 minutes to 6 hours and more than 6 hours, but less than 24 hours. Artesia, where apixaban is tried, Nova, where redoxaban is tried. These trials, expected in 2010 and 2022, will give an answer whether to anticoagulate when they have a chance to high risk score. If score is less, we don't have to do anything. And if it is more than 24 hours, again, conflicting data here, not sure. But if the heart charts to VAC score is more than 3 in a woman or more than 2, there is certain evidence to anticoagulate. Provided the AHRA, we need to review the ECG and confirm that it's true clinical AF. Then there is an indication for anticoagulation. Now, coming back to our story, 75-year-old lady. So lady, 75-year-old, 2, charts 2, hypertensive, 3. So the score here is 3. So where she falls in our scheme of things. So score is 3. That's what I wanted to know. 6 short runs of AF, the duration. If it was say less than 6 minutes, just observe, nothing to be done. If it is 6 minutes to say 24 hours, we need further evidence. Just wait for the Artesia and Nova trials. If it is more than 24 hours, I think to review the ECG, if it is confirmed to be an AF, I think we have evidence to start anticoagulation. Of course, we need to balance the risk of bleeding with the risk of stroke. If the bleeding risk is low, definitely yes. Then the whole conference is in a dramatic or cinematic style. So what about having an anticlimax for this story? This lady is a 74-year-old woman, hypertensive. It's given that occasional giddiness. There is no syncope, I agree. But a 24-hour halter is not sufficient to pick up a 6 sinus syndrome or even a post-termination followed by an tachycardia. So we need to extend the halter. Especially, this is important, especially on the day of halter, the patient did not have any symptoms. So extend the halter if it's, or you do it till the patient has his halter recorded and the patient has a symptom. If it shows a 6 sinus, this patient may end up in pacemaker. So the discussion was for subclinical AF, but can have an anticlimax like that also. Thank you. Thank you.
Thank you very much, Dr. Abhilash, for that perfect twist and anticlimax, which brings us to the end of the topics. Over to you, Taragan sir, for your comments and suggestions.
Thank you. And of course, thanks to Abhilash. I think he has discussed everything in great detail. I was having been distracted by the number of participants, which is dwindling as the program is going on. And the chat box is empty. That it's not a very good sign. But however, my duty is only to probably repeat what Dr. Abhilash says, and which I would not want to do. What I would suggest is, if a 75-year-old lady comes to medical attention, do you evaluate her for the risk of atrial fibrillation? And would you do any investigations to see if she has what is called the high or atrial high rate episodes? Now, Holter actually is in between an ECG and the implantable or the wearable devices for arrhythmia monitoring, because you actually can get electrocardiogram. So for diagnosis of an atrial fibrillation, you need an electrocardiogram which shows at least for 30 seconds atrial fibrillation, or a 12-lead ECG which shows atrial fibrillation. So Holter probably would come into what would be described as a clinical asymptomatic atrial fibrillation. It means asymptomatic but clinically significant atrial fibrillation. Now, the problem with this is now the atrial fibrillation is not, first of all, we are not shown whether the symptoms are related to atrial fibrillation. That's very important. You should have a diary which shows, because she is actively gone for an Holter with history of giddiness. Now, whether there is a matching between giddiness and the short bits of atrial fibrillation or the post-atrial fibrillation pauses, but that, of course, is not. Now, when I come to a 75-year-old lady, I would look at two things. What is the risk of stroke? And second, what is the risk of her getting a stroke due to atrial fibrillation? First, I think you should address what are the risks for stroke. It would include hypertension, diabetes, dyslipidemia, overweight, sedentary habits, past history of stroke, or even a family history of stroke. So these are some of the things which you would like to know to see if she has a high risk of stroke. Now, then you will see what is the risk added by stroke in a patient who is 75 years old. It is seen that atrial fibrillations of very short durations add not more than 0.5% stroke risk a year. Now, you see, after all, we are going to give her anticoagulants, which is a definitive treatment for prevention of stroke and atrial fibrillation. Now, would you give an anticoagulant which has a 1.5 to 2% risk of major bleeding per year in a patient whose actual risk of stroke is maybe at most 1.5 to 2? Now, with the availability of newer oral anticoagulants or the direct oral anticoagulants, where the risk of bleeding is slightly less, especially risk of intracranial hemorrhage is less, it is important that we may consider, if an anticoagulation is required, you might consider a direct oral anticoagulant in a 75-year-old lady. But however, I still feel that just transient episodes of atrial fibrillation monitored by Holter, which shows an electrocardiographic fibrillation, may still not be sufficient enough to put her on oral anticoagulation as a definitive therapy to prevent stroke in this lady, especially because her stroke risks are not much. She is only hypertensive. Obviously, hypertension is one of the most important risk factors for ischemic stroke, because it causes something like a vasculopathy in the brain and micro infarcts and micro bleeds in the brain. So I think treatment of hypertension and close monitoring whether she will go into clinical atrial fibrillation, that means whether she has symptomatic atrial fibrillation or atrial fibrillation, if you do a routine ECG, maybe the way to go forward. I think with this, I will stop my comments. If there are any questions from the chat box, both of us are ready to answer, or I would like to give Abhilash a chance to give his opinions on whatever I have. Abhilash?
You are muted, please. Can you please unmute yourself?
Sir, so happy to see you online, sir. That's my only comment.
No. See, unfortunately, the audio was not very good. For some reason, something has happened to the audio. So I couldn't catch the entire discussion of many participants. But do you have any different opinion than what I said?
No, sir. We need probably
Holter somewhere in between the subclinical and asymptomatic clinical, isn't it?
Sir, now they say
clinical is usually the atrial high rate episodes by wearable or implantable or insertable devices.
Yes, sir. Now they
or
say
even by some of these people who use the smartwatches at all.
Yes, sir. Now this, if we can review the Holter again becomes a bridge between these two. If we can review the Holter and confirm that it's an atrial fibrillation, probably we can take it as equal to a 12-lead ECG. And probably we will be
Then you would go by the chat score for initiating atrial fibrillation therapy like oral antibiotics.
Yes, sir. We will get probably by next year, sir. We will have a better idea with this NOVA trial and edoxaban.
Yes, we're all waiting for those two. But there, if you look at those two trials, we are not sure whether this atrial fibrillation is per rate duration or the total atrial fibrillation load. That means sum of total atrial fibrillation load or individual maximal atrial fibrillation duration. Now that is a little concerning. I'm not sure what they mean by 24 hours. Is it a single episode of AF?
Sir, single episode more than 24 hours, sir. But even then,
I presume it is a single episode, but I'm not so sure.
But I even in those
maybe also atrial fibrillation duration, or I mean overall load.
Yes, sir. Even in those cohorts, the doctors started anticoagulation only 13% when the duration was more than 6 minutes, and only 27% when the duration more than 24 hours. So almost 75% of doctors are still skeptic.
Yes. And even if they start, they give it very low dose. It is called pediatric dose for adults when you are not sure you are doing right. Do you think an MRI should help in 75-year-old lady if she has multiple subcortical white infarcts or something like that, which may be or you think it is a non-specific?
Sir, MRI brain.
Yeah.
Maybe, sir. But MRI of the heart, LA, how much remodeling it has happened, how much the fibrosis.
Okay, you want to basically, yeah, that's right. You look at both the substrate for atrial fibrillation as well as atrial fibrillation. Yes, you're going too much on the electrical component, but we should actually go to the structural component that is left atrium. Yes. This patient, the left atrium is mildly enlarged. And of course, there is a diastolic dysfunction, may not be diastolic heart failure. Yes, I think we must address the morphological, structural, as well as electrical changes in the atrium to decide whether these patients may be benefited from oral antibiotics. Right?
Yes, sir.
Thank you.
Thank you, sir. Thank you, sir, and thank you, Dr. Abhilash, for the excellent discussion. So all good things must come to an end. May I request the chairman of the scientific program to have the final words before we have joined the GB.
Thank you.
Thank you very much,
Abhilash and Sajan, for what I call as a minimally invasive coordination and streaming of talks and time. I think the session was an extraordinary event, a sort of a jugalbandi of sorts, our youngsters and our stalwarts. And some sessions, I think you must have noticed that it was like Amjad Ali Khan performing with his son, Aman, and often encouraging the young man during the concert. I think, thank you very much. Thank you again, Johnny and Karinadas, for the opportunity. Thank you, and now have a nice day. Have a nice lunch after the GB and welcoming session. Thank you.